morning to all. I'm Dr. Swati. I'm the consultant in Birla Fertility and IVF Kolkata, and I'll be your coordinator today. I'd like to welcome you all to yet another day of ACE academic field. To start with the first session, I'd like to introduce our chairperson for the session, Dr. Sudha Tandon. Dr. Sudha Tandon, ma'am, she is the director of Sudha Tandon Fertility IVF and Gynec Endoscopy and Maternity Hospital. She is a valuable contributor of organizing chairperson as the Moxie Age Endo Art Conference Workshop in Mumbai 2018, live operative Gynec Endoscopy Workshop of Maharashtra chapter of IAGEN SAR. And she was a Foxy chairperson of Sexual Medicine 2017 to 2019, managing committee member of Mumbai Obs and Gynae and MOG since nine years, managing committee member in the Association of Gynecology, Endoscopic AIGE for 6 years, president of Surgical Association of Chembur 2017-2019, national coordinator of AUB workshop 2017 awards, and elected committee member of ISAR 2020-22, elected committee member of AMC 2021-22. And she has AICOG January 2002 Best Presentation Award at 46th All India Obs and Gynae Conference at Orissa on fertility enhancing hysteroscopic procedures. A very welcome to you, ma'am, and over to you. The stage is all yours now. Thank you.
Thank you, Dr. Swati. And good morning to all of you. I think it's a very wonderful Sunday to begin with. The climate has just settled. It stopped raining, which was, I was just speaking to our speaker, Dr. Chatterjee. So without wasting any time, can we have his CV, please? Because he's going to speak on a very important topic of fibroids, infertility, and what to do with the fibroids, you know, if patient is going for ART. So Dr. Abhinibesh Chatterjee is a diploma in gynec laparoscopy from Germany, FRCOG UK, DNB, MBBS DGO. It's consultant at the Columbia Asia Hospital, Kolkata, trained in India, UK and Germany in advanced gynec endoscopic surgery, member of AAGL, which is the endoscopy federation from USA, chairman of endoscopy committee of BOGS, Limca record holder for removing maximum fibroids from a single uterus. That's interesting. Conducted many hysteroscopy and laparoscopy workshops and has helped in many state and national level live workshops and conferences. He has presented and published many papers and also is an author of 2 books and contributed chairperson chapters in international books as well. Presentation at FIGO 2012 and 2015, video presentation at RCOG World Congress at Birmingham in 2017 and London 2019. Dr. Chatterjee is going to speak about fibroids and infertility and whether to operate or not to operate before ART. Well, I must tell you, friends, it is really a dilemma because you know, each patient comes with a different mindset, different views about fibroids, and sometimes they're ready, sometimes they're not ready, and we really need to convince them. So stage is all yours, Dr. Chatterjee. Please go ahead and enlighten us.
Thank you very much, ma'am, for the kind introduction, and I will just start my presentation. Now, fibroids should be operate before ART. Now, the learning objectives of my presentation is distinguish between the different types of myomas to judge the benefit or necessity of performing a myomectomy, to debate the necessity of a more accurate classification. Now, coming to epidemiology, 20 to 40% of all women in reproductive age are affected by leiomyomas. Myomas directly or indirectly are associated with 5 to 10% cases of infertility. Now, depends on the size, location, number, types. 20 to 50% of fibroids have symptoms of menorrhagia, dysmenorrhea, infertility. Bleeding, pain and pressure, urinary symptoms, pregnancy, infertility, recurrent pregnancy loss, obstetrical complications, and some may be asymptomatic as well. Infertility and myoma controversial because difficult to prove causal relation. Review of previous 70 to 80 studies indicates a pregnancy rate of 50% after myomectomy in infertile patients. No well-controlled randomized studies, no clear description of size, number, and location, no standardization of diagnostic methods, different outcome parameters, result varying from 10 to 70% according to donors. Infertility and myoma more common in IVF patients because of the delay of childbearing when fibroids are more common, but also age decreases fertility, so they are more common. The impact of uterine myomas on fertility: greater distance for the sperm to travel, encroachment of the tubal ostium, occlusion, distortion of the uterine cavity, vascular changes interfere with normal rhythmic uterine contraction, impaired implantation, abnormal endometrial maturation, alteration on the oxytocinase activity. Now, mechanism of impaired fertility in case of intramural or submucosal fibroid. Richard et al. Showed that number of caveolae in host myometrium and fibromyomata are conceivably decreased compared to normal myometrium. This specific structural abnormality may affect the calcium metabolism by causing a decrease in the defect calcium extrusion and thus raising the intracellular calcium. Increased intracellular calcium produces myometrial irritability and hyperactivity, resulting in disruption of the rhythmic contraction process of the junctional zone. Again, another studies by Zamatovich et al. In 1997 showed reduced contractile pressure in the presence of fibromyomata, which increases following myomectomy. Subendothelial tumors causing endometrial erosion with subsequent inflammation, altering the nature of the intrauterine fluid, resulting in a hostile environment, disrupt the endometrial blood supply, affecting nidation and sustenance of early embryo. This is Farry et al., which had done a study in 1995. Now, coming to the most important part is the uterine leiomyoma classification. Based on the concept, the fibroids are primarily interstitial and gradually either forced outwards or inwards. If forced inwards, they become submucosal, intramural, and if forced outwards, it becomes subserosal. Now, the proposal of classification, submucosal or the junctional zone fibroids, type 0, type 1, type 2 are classified as submucosal, and type 3 is just abutting the endometrium. Now, the outer myometrium fibroids, that is the type 4, which is intramural, and type 5 is subserosal, and type 6 is pedunculated. This is the standard classification which we are following. Now, this is the structure of the uterus, which is broadly classified into the outer myometrium. These fibroids in the outer myometrium doesn't cause much of a problem. But the fibroids in the inner myometrium, that is the junctional zone, is the fibroids which cause problems with subfertility. Now, we are more concerned with the junctional zone myometrium. Functional important entity in reproduction, ontogenically related to endometrium, cyclical changes in SSH receptors, role in gamete transport and implantation. Junctional zone myometrium, important role in reproduction, functional important entity in reproduction, early changes from time of implantation, decidualization and trophoblast invasion, defective transformation zone of junctional zone spiral arteries in the spectrum of pregnancy complications. Now, the outer myometrium, less important role in reproduction, muscle contractions during delivery. That is the only important function of the outer myometrium. Now, impact of myoma on fertility. This is a review by Donez et al. We have seen the pregnancy rate has improved after myomectomy in most of the studies with cavity distortion by fibroids. So that is very important. If the cavity is distorted, obviously myomectomy will improve the success of ART. Fibroids affecting IVF results. This is a review by Pritt et al. 11 studies, 3 prospective controlled, 8 retrospective controlled, no randomizations though. Women with otherwise unexplained infertility, location of fibroids related to pregnancy, implantation, and deliveries is very important. Submucosal myoma and infertility in IVF, we have seen that it has, after resection, in all studies, pregnancy rate improves. Myoma and infertility review again, conclusion was subserosal fibroids do not affect fertility or spontaneous abortion rate. Submucosal fibroids lower fertility and myomectomy enhances rate of conception and live birth. Intramural fibroids with or without distortion of the uterine cavity may cause a detrimental effect on conception and reaching viability with pregnancy. If those, all the studies has suggested effect of myomectomy is unclear. Now, submucosal fibroid, so it is convinced that if there is a submucosal fibroid, it needs resection. Summary of all data from IVF model shows that patients with fibroid distorting the endometrial cavity have impaired implantation and pregnancy rate. This was again a study by Somigliana et al. And also Rackrow and B. Taylor found that submucosal fibroids have a global decrease in endometrial Hox gene expression, a molecular marker of endometrial receptivity. Now, effects of intramural myoma. This is the controversial area. A plausible mechanism for intramural fibroids not distorting the cavity has been seen as a possible disruption of the junctional zone within the myometrial layer at the initial stages of embryo invasion and placentation. Again, a study suggested intramural fibroids negatively affect IVF results. This is by Hart et al. Intramural fibroids do not affect IVF results. This is study, 3-4 studies have suggested that. So again, as I told you, it's a controversial area. Effects of large intramural fibroid. Large means more than 5 centimeters. Hart et al. In Human Reproduction has published that large intramural myomas negatively affect pregnancy outcome after IVF. So large intramural myomas should be removed before the IVF. Now, large myomas, if myomectomy is beneficial in patients before IVF, it do not necessarily means that myomectomy should be performed systematically in women trying to conceive, not needing an IVF treatment, because risk of adhesion formations after myomectomy is there. Intramural fibroids smaller than 5 centimeters. Then what to do with them? Should they be disregarded? Should we operate before IVF? Should we operate after IVF failure? If so, after how many IVF failures should we operate before any infertility treatment? Should the decision be influenced according to the cost of IVF in different countries? So these are the questions which crop up in our mind. Intramural fibroids smaller than 5 centimeters. Check et al. Did a study, no difference in implantation rate and pregnancy rate, but they find a lower delivery rate and higher rate of miscarriage. Conclusion, more studies are needed. Now, Oliveira et al., no effect on pregnancy rates and no incidence of miscarriage, but only 1 cycle they had studied. Now, influence of small intramural fibroid cumulative outcome have suggested pregnancy rate is lesser than the control. So again, as I told you, it's debatable. Intramural fibroid and cumulative outcome in assisted conception, 40% reduction of success rate in each cycle. So is it worth removing them? I should say, yeah. Is intramural fibroid a misnomer? the intramural fibroid should be classified as either outer myometrium, which doesn't cause any problem, or a junctional zone fibroid. So if it is in the junctional zone, we should consider doing a myomectomy. Uterine myoma and pregnancy, this is the Washington State Birth Record, retrospective population-based study from 1987 to 1983. 2,000 plus singleton pregnancies, comparison group selected randomly, matched by birth year, no match by age, parity, race, ethnicity. Their studies, uterine myoma and pregnancy, has suggested increased risk of abruption, first trimester bleeding, dysfunctional labor, breech presentation, and cesarean delivery with pregnancy with myoma. Now, leiomyomas and infertility, it is rarely probably that they cause infertility, but it has been described a longer seeking of pregnancy, a reduction of success rate of ART, relation with spontaneous abortion, a same probability of pregnancy after myomectomy compared to patients with no uterine pathology. So you see the studies and the evidence are very controversial. We have all quoted all studies here. Now, risk of myomectomy, as we all know, is the morbidity, infection, blood transfusion, complications of laparotomy and or laparoscopy, and postoperative adhesion formation is the most significant complication. Now, coming to conclusion 1, despite the lack of randomized studies, the sharp decline in pregnancy rate in case of submucous myoma is quite convincing, and myomectomy should be performed before ART. Decreased clinical pregnancy rate, implantation rate, live birth, and increased abortion rate if you don't do a TCRM. Conclusion 2, intramural myomas, more controversial, lack of homogeneous opinion, decreased fertility, increased pregnancy loss, and whatever effect of myomectomy. Consensus, intramural myoma more than 5 centimeter, advised to operate before ART, mostly distorting cavity. Now, coming to intramural fibroids less than 5 centimeters, reported outcome varies between no difference and significant decreased cumulative pregnancy rate. Conclusion 3, controversies in final conclusion are probably due to differences in investigations between the different studies, lack of properly performed investigations, need for standardization, evaluation related to distance to and or involvement of the junctional zone, need of randomized studies. Now, conclusion 4, obstetric outcome is abruption in placenta, cesarean section, preterm delivery, breech presentation, and pregnancy losses. Now, I will show you a few videos of some myomectomies done.
This is a case of large anterior cervical fibroid around 12 centimeter in size, where we are doing a laparoscopic myomectomy and we are doing temporary clipping of the uterine artery to start with. You can see this is on the right side. We dissected the ureters and then we are dissecting the internal iliac artery. The gateway to the pelvis is the round ligament. We have cut the round ligament on the right side. Now we are pulling on the obliterated umbilical artery, and you can see it can be seen pretty clearly. Now we are dissecting the uterine artery at the origin using harmonic scalpel and bipolar sealers. So after dissection is done, LT400 clip is applied, which will be opened afterwards. Similar dissection will be done on the left side as well, where we initially cut the left round ligament, which will be again stitched up with Vicryl at the end of the procedure after opening the clips on the uterine artery. Once you open up the round ligament, you get ample space in the pelvis. This is on the left side. You can see the internal iliac, the uterine artery, the obliterated umbilical, and the ureters. Again, same, after dissecting the uterine artery, we are applying the LT400 clip at its origin. Now 1 ampule of 20 units of vasopressin will be dilated in 200 ml of normal saline. You can see the ureter. Vasopressin is being injected into the fibroid, and then we are using harmonic scalpel. As it's an anterior cervical fibroid, the bladder is actually pulled up with the fibroid. So you need to dissect the bladder peritoneum and dissect down the bladder, because these are very chances of bladder injury. We are using harmonic scalpel to dissect down the peritoneum, and once this is done, we push the bladder down such that the fibroid pops up clearly. So once you see the big fibroid popping up, now you will plan your incision. It is advisable to always leave a capsule for easy stitching and hemostasis, and also if you try to take the entire bulk out, there will be troublesome bleeding from veins which will be coming out from the cervix and also the vagina. So you can see we are using a monopolar hook for incision, and we are trying to preserve the capsule of the anterior cervical fibroid. Mostly the myomectomy is done by traction and counter traction. You have a vaginal assistant, a vaginal manipulator as well, who pulls the uterus down, and you are with your 10 mm myoma screw pulling out the fibroid. Also, the base needs to be vessel sealer being used at all bleeding points. You can appreciate minimum bleeding because of the temporary ligation of bilateral uterine arteries. Now, once the myomectomy is complete, look for any other small fibroid which needs to come out as well. Now we are using a barbed suture for stitching. Full thickness stitches are being taken in the first layer, and usually we stitch in 2 layers, where we take the superficial layer in the second layer. And finally, on the 2 sides we put a knot in the end with the 2 threads which we have used. 1 thread has been used for the inner layer and 1 thread for the outer layer. Any small fibroids also need to come out, otherwise this will recur after a while and big large fibroids. You can appreciate there is a posterior wall adenomyoma which has been taken, and this has been stitched with Vicryl 2364 to achieve hemostasis. The round ligaments will be also stitched with Vicryl, and finally the LT400 clips are being taken out from the uterine artery, first on the left side and then on the right side. Very easily you can appreciate the vessels will be pulsating once again once the clips come out. Be very gentle while you are pulling out the clips. The pulsation of the uterine artery is well appreciated. Thank you very much for watching this video.
So I'll show you one more video of a submucous fibroid, bipolar TCRM being done. Here also posterior wall myoma around 3 centimeter. It's almost type 1 type of fibroid which needs to be resected. The bipolar uses is very safe, use normal saline, and the chances of fluid overload is less because you can allow a deficit of about 2.5 liters of normal saline. You need a cautery machine which has a saline underwater cut mode and set at a bipolar pure cutting of around 70-80 watts, and you activate your foot piece first before touching the tissue and take big chunks. So you need to complete the procedure quickly. You need a good histromat or endomat for a good distension and also input-output measurement. You keep your intrauterine pressure around 100 to 120 millimeters of mercury, a flow rate of around 250 to 500 ml of normal saline, and just go on cutting big chunks such that you complete the procedure pretty quickly. Mostly do backward cuts and minimum forward cuts, always under vision. Cut quickly. This procedure you have to complete quickly because of the chances of fluid overload, especially with big fibroid. Here I have just given a few touches of forward cut as well, but ensure to complete the procedure. Don't leave any remnants, otherwise they will recur. So with this, I think I will end my presentation. I'll show you one more small video of hysteroscopic morcellation, which is very easy for learners. This is the Baghetti shaver of Karl Storch, which has been used. You just have to introduce through your nephroscope or a hysteroscope, which has an operating channel. The Baghetti shaver goes there, and you place the shaver on the myoma, and it will just carry on shaving the tissues. You don't have to do anything. It's an expensive device, but once for learners, it is very easy to pick up. Even big fibroids can be done with this, and it shaves and sucks, and the view is very good. So all submucous fibroid has to be taken out before you plan to do ART, and all fibroids more than 5 centimeter distorting the endometrial cavity needs to be taken out by doing a laparoscopic myomectomy before going to ART. With this parting comments, I end my presentation. Thank you very much, organizers, for giving me this opportunity. I'm really grateful to Chairperson and Dr. Swati for allowing me the extra time. Thank you very much, ma'am.
Thank you, Dr. Abnivesh Chatterjee. I think it was, you covered the topic very well. You know, most important, you really, the important points, when to operate, when not to operate, and with lot of evidence-based slides that you showed, I think it was really very excellent. Can we have few questions? Is there any questions in the chat box, Dr. Swati? Or hello?
Hello. Yeah, there are no questions, ma'am, but you can ask if you want to, please.
Yeah. Dr. Chatterjee, I would want to know, you have done resection and with the Baghetti shaver, both you have done for hysteroscopic myomectomy. Am I correct?
Yes, yes.
Yeah.
Yes,
so now have you switched over to the Baghetti shaver?
No.
Hysteroscopic morcellation?
No.
You do
bipolar section. Previously, we used to, Paul sir is also here. I'm a student of Paul sir.
Okay, good morning, Dr. Paul.
Whatever I'm doing today is because of Paul sir.
Okay,
I learned from Paul sir only doing monopolar. At that time, we used to all do monopolar using glycine. But once bipolar came, we shifted to bipolar. It is much safer for the patient. But the procedure remains the same. So we are doing bipolar resection mostly. Baghetti shaver is only for conferences where they give the shaver, because I don't have the shaver myself.
Yeah, so
suppose you were, it is very, very
suppose you were given a choice, you don't have to spend. So between the two, what would you like to have?
Well, I'll go for the bipolar because it is faster. Once you become trained, you tend to do it very fast with resection than the shaver.
Yes. Dr. Paul, do you have any comments on this, please?
I also tried with different shavers.
Right.
The main advantage is it keeps a very clear view. That's excellent. You don't have to come back and remove the chips.
Right.
The disadvantage is they are not as small as our smaller resectoscopes. They are almost, I think, 7 to 8 millimeter. And you need a dedicated instrument for that. You cannot convert your diagnostic scopy into a smaller resectoscope.
You need a nephroscope through which it goes, sir.
So those who are doing already resectoscopic surgery, there is no major advantage. But those who are beginners or those who have a lot of small polyps, small fibroids, and you are not trained in resectoscopy, then this is a good instrument.
Right. I think it's important to know because so much is there in the literature, and you need to know because it's an expensive equipment. and not all can afford it in their private setups. That's what I personally feel.
Yeah, that's true.
Yes.
But
So
with resectoscope, you just need to, if you are having a monopolar resectoscope 26 French, you just need to change your working element. The same monopolar other sheath and outer sheath and the scope will work. You just change your working element and buy the loops and the cord. And
right.
obviously you need a cautery, saline underwater cut cautery machine. But now all Indian companies have this mode. So it's not a big investment. It's an investment roughly around 2 lakhs, and you can shift to this bipolar resection easily.
I think it's a very valid point that you have made. When you buy an electrosurgical unit, see that it has bipolar underwater, for cutting for hysteroscopy. Yeah, because though all of us have done monopolar cutting, and very few occasions we have had issues, few of us have had, but by and large, it was pretty good and very fast and big chunks that we were removing. Now, suppose there is a patient who has a fibroid with the what is your limit of doing hysteroscopic myomectomy is what I would like to know. Now, suppose you have about 5 centimeter fibroid, 60% is projecting into the cavity, 5 centimeters fibroid, 60% projecting in the cavity. Would you do laparoscopy? Because these are, dilemmas which...
Ma'am, mostly fibroids, if ultrasound suggests it is more than 4.54 centimeter, I normally do a hysterolaparoscopy in the same setting.
Right.
And my limit will be the fluid deficit. If I see I have used more than 3 liters of saline and the deficit is going towards 3 liters, I will go for a same sitting. I don't go for 2 sittings. I will go for, I'll do hysteroscopy, and if I can't complete it, I'll do a laparoscopic myomectomy in the same sitting. The advantage of doing a laparoscopy is you can suck out the intraperitoneal saline. So obviously the fluid deficit decreases that way. And if you fail to complete it hysteroscopically, I would do a laparoscopic myomectomy and complete it. So because we are all in private practice, I don't believe giving the patient a second surgery is cost effective for the patient.
Right.
So I
But
complete in the same sitting.
yeah, but this absorption is not just because what is in the peritoneal cavity, but it is into the intravascular space.
Yeah, I understand.
That,
but if you don't do a laparoscopy,
I understand.
the excess fluid, you can see if at least there will be 500 1 liter of
Yes,
peritoneal
I
fluid.
agree. I agree.
Needs to be
But
sucked up.
what I would want to know
Ultimately,
is,
that will also be absorbed, no? So
Yeah.
that increases the fluid overload.
so what is your cutoff to decide whether you do hysteroscopy or you do laparoscopy for a 5 centimeter, let's say, fibroid? Is
Again,
what
fluid deficit.
so you would for FIGO stage 1 and
I
even
would
for
start
stage 2,
definitely hysteroscopically.
even
but
for stage 2 fibroid or stage
if it is aborting the endometrial cavity, I would have a go with hysteroscopy. If I find that if it is not, I mean, the fluid deficit is increasing, then I will shift to lab.
But don't you think we are damaging the endometrium
In all myomectomy, that doesn't make any difference. You made a small endometrial damage. If it heals well, no?
Okay.
Don't have any issues.
Dr. Paul, what is your take on this?
5 centimeters, I think it's quite big, and normally it's little difficult to complete in one sitting. So I give the option to the patient. If you want to completely remove in one sitting, I will do most likely a laparoscopic myomectomy. But if the patient insists on doing, then I will say, I will try, but most likely you will end up in 2 sittings.
Right.
That's my take.
Yeah, I think I agree with you, because that would be, because anyway, you're doing laparoscopy, so why not do one procedure, finish the myomectomy laparoscopically. All right. Thank you very much, Dr. Chatterjee, for your very nice talk.
But ma'am, laparoscopy, obviously the controversies of adhesion is there. So I have a clear conscience. I tried it hysteroscopically, but because of the deficit, I could not complete. So I go for laparoscopy. So I give the benefit to the patient because all studies have suggested, even in expert hands, laparoscopic myomectomy, there is concern with adhesions and natural conception because of adhesions.
Yeah, but I think even when you do hysteroscopic myomectomy, that is the biggest reason for having intrauterine adhesions is hysteroscopic myomectomy. So that is also one issue which
All
can.
studies have suggested if you do a multiple hysteroscopic myomectomy, means anterior wall, posterior wall, then there is adhesion. But obviously, if you can control the bleeding and if you don't leave bleeding, the chances of adhesion is minimal.
All right. Dr. Paul, would you like to comment or ask, discuss? Because there's a change in the plan. There's only one speaker for this
The
session.
problem is you go on struggling hysteroscopically and towards the end you change over to laparoscopy. Is little unpleasant and it takes a lot of time. So I normally either decide whether I do hysteroscopically. If they only willing for 2 sittings, then only I will proceed for a 5 centimeter. Definitely by during the surgery, intraoperatively, I definitely reassess and find out whether it can be done in 1 sitting. But most likely taking out 5 centimeter myoma hysteroscopically is quite tough job. A lot of removal of chips and repeated getting into a cavity and all. And sometimes you get a good distended cavity, then it's fine. But most of the time you may not really get a good distension to cut very fast. So I insist on saying if the patient is willing for 2 sittings, I will try hysteroscopically. Otherwise, I will reassess on the table and decide most likely laparoscopic myomectomy.
Yeah, I think doing one procedure makes sense because when you have a patient who's got, whose fluid deficit is about 3 liters and then you're continuing with the anesthesia and the surgery, possibly it may not be the safest. That is what I personally feel. It's better to decide beforehand as to what you would like to do, whether you do laparoscopy or you're doing hysteroscopy. And I think MRI would probably play a good role for deciding as to mapping of the fibroids and deciding and discussing and counseling with the patient. That is what I personally feel is, I personally do that.
But if you are a real expert, then if you are used to do such large myomas, then probably you can.
Yes, so I think very true, very true, very true. It is the personal
Experience.
expertise is very important. I agree. Yes. So any other discussion you would like to have, Dr. Paul?
I think it's my panel discussion. So
Okay.
for the discussion.
All right. Thank you very much, Dr.
Thank you.
Chatterjee, for the wonderful lecture. And since the other 2 speakers were not there, we had good time to discuss about fibroids. And thank you very much, organizers, for having me here as a chairperson. Thank you, Swati, for the kind words. And congratulations to the organizers for a wonderful program that is going on. And nice to see you, Dr. Paul, early in the morning.
Yes. Thank you.
Thank you, Dr. Chatterjee, for such an information-filled presentation. And thank you, Dr. Sudha Tandon ma'am, for sharing the session and sharing your interesting perspective and also making the session so interactive and so interesting for all of us. And thank you, Paul, sir, for also contributing your thoughts and also like giving your interesting views in this. And thank you for a wonderful first session of the day. So we will move forward for the panel discussion. Right now, I think all the speakers have not joined. So once they'll join, then we will move forward for that. So.
Yes, ma'am. They are joining in just 5 to 10 minutes. I have called Dr. Sanjeev and Dr. Amit, sir. Then joining in 5 to 10 minutes, ma'am.
So should I go ahead and
what do you like, sir?
We'll wait for 5 to 10 minutes for everybody to join.
Yes. Yeah, I think that will be better.
Once they join, we can start.
Yes, sir.
Yes.
Yes, sir. Hello. Swati ma'am. Hello.
Should we start? Hello.
Amit Tajani is joining in sometime. His internet connection is not stable, so he's joining from other device. And Dr. Sanjeev Bera maybe join in few minutes. So can we start till then?
Oh, yes, we can start.
Sure, sure, we
Okay.
can start.
We have one panelist, Dr. Polly Chatterjee. So we can start the session now. So I am giving you the countdown, Swati ma'am. Then you
Okay.
will introduce Paul sir, and Paul sir will take over then session. Okay, sir.
Sure, sure. Yes.
Okay. Okay, it's 5, 4, 3, 2, 1. Start, ma'am.
So after such an interesting first session, now we are moving forward for our panel discussion. And the panel discussion will be on the challenging reproductive surgical scenario, case-based discussion. For this session, I'd like to introduce the moderator of our session, Dr. Paul PG, sir. Dr. Paul is a chairman of Paul's Hospital, Kochi, India. He's a board member of ISGE 2012-16, elected member, the Society of Reproductive Surgeon, ASRM, since 1997, authored 2 books and contributed 41 chapters in books, published 50 papers in international journals, invited review articles. Invited lectures, 383 live surgery workshops, and 242 webinars of 33 webinars. Given hand-on training to more than 1,800 gynecologists in gynecological laparoscopy, and lifetime endoscopic empowerment award was awarded to him by the IAGE in 2018. Distinguished Alumni Award from Trivandrum Medical College in 2019. A very welcome, sir, and the stage is all yours. And please go ahead and introduce us, our panelists. Thank you, sir.
Thank you, Swati. I'm really happy to be part of this Boston conference, ACE 2021. And can I share my screen? I'm just we are going to have a panel discussion on challenging reproductive surgical scenarios. I will be showing few real case scenarios where we encounter difficulty during the surgery or making a decision how to proceed with the surgery. And we have a panel of experts with us, Dr. Polly, Dr. Amit, and Dr. Sanjeev, for giving us their inputs, how they would have managed the same situations. And that would be useful for our younger colleagues who have not really faced such difficulties. I would like to introduce Dr. Polly. She is a friend of mine. I have visited their places many a time in Kolkata. She's a consultant at Columbia Asia Hospital. She has conducted many national level live surgery workshops and conferences. And very interesting, she hold a Limca record of removing the maximum fibroids from one case. She has published many papers, 2 books, and several chapters in national books. She had represented FIGO in 2012 and 15. The other speakers, Dr. Amit is from Archit Hospital. He's an executive member of FOXI International Academic Exchange Committee. He's a joint secretary of NASIC OBGYN. His special interest is endoscopy and ART. Dr. Sanjeev, he's from Bhubaneswar. He is a consultant at AMRI Bhubaneswar. He has presented several papers, and his skin is very regular participant in many medical quiz competition, has won several prizes in those quiz competitions. My first case is a 34-year-old woman with severe dysmenorrhea. Now she has continuous pain since 2 months. She's a case of infertility of 8 years. And previously, 3 years back, she had a conservative surgery for endometriosis. And because of the pain, she was put on Dynogest since 2 months, but there is no pain relief. And the ultrasound scan showed a cystic mass of around 7 into 6 centimeters, septate 1, and the almost ground glass appearance, but maybe a little more coarse echoes in this particular case. So definitely she needs a laparoscopy, and the laparoscopy was performed. Laparoscopy, as expected, has a lot of rectosigmoid adhesions, and both adnexes are also adherent to the pelvic side wall. And we started releasing the adhesions slowly, and to our surprise, a lot of pus came out from one of the ovary where we had suspected a chocolate cyst.
Good morning, sir.
Good morning.
Sorry, sir, I couldn't see your videos, and I couldn't see. I think we need to share the screen. We can't see the video.
You
Or
cannot
we can't see the picture. No, sir.
Oh,
It can be seen by me. So just let me find out if.
Okay.
I am sharing my screen, so just find out whether.
Yes, sir. Yes, sir. Now I could see. Yeah.
Okay.
Sorry, it was my
Okay.
problem on my side.
Oh, okay.
Yes, sir. Sir, sorry, sir. Could you please repeat the question? And
I will start.
yeah, thank you. Thank you, sir. Good morning, sir.
Good morning.
To all of you.
We started releasing the adhesions, the rectosigmoid, and to our surprise, the chocolate cyst we diagnosed was actually an ovarian abscess. So my question is, Polly, how will you diagnose this? Actually, I had not diagnosed this preoperatively. Is there any way we can think about this possibility or make a diagnosis before because this is something different where we cannot really do the surgery what we had promised to the patient.
Definitely, sir. So from the history, if there is any previous history of any temperature or suggestive of PID, like pelvic inflammatory disease, and any pain or any temperature for a long time, it's a cold abscess, it seems. It's not an active infection at present, but any history previously of this type and increased CRP and all the investigations when we see, there is a lot of adhesions, and from going from the history, maybe a past history, 1 or 2 months back, she had a lot of pain and fever, which was not reduced with oral antibiotics, and she needed some IV antibiotics for that. That might lead us to think that there might be.
That's a good point, Polly, because actually when we went back to her history, she had several months back, she had a few episodes of abdominal pain and fever, which was treated with antibiotics, and it subsided. Yes. But another thing we got a clue was, even with the Dynogest, she was not responding to her pain. And we had done CRPs in few other cases where we actually suspected. But since they are in dormant stage, sometimes you may not have a raised CRP. Yes. So this pain not responding to any this endometriosis suppression, or if you look at previous history, so any previous surgery for endometriosis for that matter, you should something of keep in mind that it, and even ultrasound was slightly different. The ground glass appearance was not typical. So all ground glass looking like may not be true endometrioma. So you must think about it. So my next question is, how to proceed with this surgery? Will you do a cystectomy or adnexectomy?
So in this case, she is a nulli gravida, she's planning for pregnancy. Basically, we need to clear the anatomy as much as possible, drain the pus and keep a drain. Maybe we will do the case later on in a second sitting. It's much better not to do any special treatment, like definitely not adnexectomy, but we have to counsel the patient, tell the patient's husband that this is a finding we got, and if you're doing at the same time, the total treatment might not be, we might not do a total treatment. So drainage of the cyst, and you can always try go for a biopsy. Definitely take a biopsy. As much cyst you can remove, you can do, but the total treatment can be done maybe after a later stage where the infection and everything has been settled, and then we can proceed again for a second look laparoscopy.
I think that's a good point. Sometimes we may not be able to make a good decision at this point, and we may drain this and, as you said, take a biopsy and come out. But I thought we'll just find out how extent. Then I found it was a chronic cavity. I could actually enucleate it. Definitely, we can expect a fever and little turbulent postoperative period. But with higher antibiotics, she responded well. And later on, I think we did IVF or something like that. This is another woman, 43-year-old nulli gravida, severe dysmenorrhea, and trying for pregnancy since 1 year. It's a second marriage. She had actually 4 cycles of IVF in the previous cycle, and ultrasound showed an enlarged uterus with an anterior adenomyoma of almost 7.9 into 6.6 centimeter. This patient want to become pregnant at any cost. So what will be your advice? Whether you will advise IVF or probably with the donor egg, or you will treat the adenomyosis? What is your...
Basically, she is 43 already. So we need to just check on all the fertility potentials, like whether what is her age, what is her antral follicle count and everything. And once we have checked for all the things and she's keen for pregnancy, it's better, it's going for adenomyomectomy, because we need to treat her pain as well as give her pregnancy.
That's true.
So the junctional zone myomectomy, we just need to take out the adenomyoma, even if it is not in toto. If we remove a bit of adenomyoma, almost like a glioma, if we take out almost about 2 to 3 centimeters, also it will help us with the, it will reduce a lot the pain and other things. So
I also agree with you, because she has severe pain, and we could actually, it was a localized anterior wall adenomyoma. So we planned for an adenomyomectomy. Do you have any, because adenomyomectomy is little different from myomectomy, do you have any special technique to perform this?
Yes, sir. We normally do it. We do a wedge resection of the adenomyomectomy. It's very difficult to close the myoma bed. So always we need to keep some, not like fibroids. In fibroids, we can remove the skin. But in adenomyoma, it should be, the skin should be kept, and it should be a wedge resection. So basically, you need to pour out the adenomyoma from inside. And as much as you can pour out, the result is much better. And we have got many pregnancies after adenomyomectomy. So it's very important to counsel the patients. And definitely, even if you're taking out 1/3 of the adenomyoma, the pain reduces a lot. And from that case, point of view, the pain and dysmenorrhea, adenomyomectomy has a wonderful role. And IVF, definitely she has to go for IVF with a donor oocyte in this case?
I agree with you, Polly, because adenomyomectomy, if you take a wedge, it's very difficult to close. So people have been trying out different techniques like Osada's technique or inverted T-shape or what you call H-shaped incisions. And what I have done in this particular case after seeing, reading some article is we point with the harmonic, you can see I'm making a marking of the limits of the adenomyoma, and we are actually making a cruciate incision. The other author described it as a 4-petal incision. So you can see the mark. So you extend your incisions across, you make, and you make a flap out of the pseudomuscularis part. So 0.5 centimeter thickness flaps are made on each cruciate or the 4 petals, and you keep that flap because you need that for approximation. Otherwise, finally, such a big adenomyoma if you enucleate, and the thickness actually you go according to the ultrasound findings, and you can see once you make a cruciate incision, it's easy to pull out this type of bigger pieces. And sometimes we do a hysteroscopy to find out and transilluminate how much you can see laparoscopically. So we really took out, dig out the maximum amount of adenomyosis. And we normally close nowadays, or even since long time we use a barb suture, and our aim is to actually obliterate. And here you can see the flaps are quite large. Actually, you can overlap, and overlapping is a good technique to reduce the uterine rupture during her pregnancy. Some people use a mesh over this, but definitely any mesh is sometimes gives problems. So what we are doing is overlapping and closing the defect and reinforcing the myometrium.
Yes,
So my question is, after how long you wait to go for further treatment to conceive, and any advice during delivery?
So we routinely advise to ask the patient to get pregnancy after 6 months.
Okay.
Minimum.
Nice meeting you. I already introduced you.
Yes, sir. Thank you, sir. Same here.
Polly, you have any comment?
Yes, sir. We need to at least 4 to 6 months because the total thing needs to be healed up nicely so that there is no risk of uterine rupture. So we normally go for 4 months. So after 4 months, she can be tried for the IVF and other things. And all throughout the pregnancy, we have to keep an eye, especially ask the sonologist to check for any thinning or any patient. Also, we counsel and we give progestogens all throughout the pregnancy so that the uterus relaxes.
I think many people wait 3 to 6 months. I normally wait 2 to 3 months because we think that the wound healing will be almost complete in 8 to 10 weeks. That is what most of the studies have shown. Whether waiting for longer will make a difference, that's left to you. But this patient is already getting older, and we normally do it after 3 months. But definitely there's no harm in waiting for the standard 6 months advice. Definitely the technique of myomectomy make a lot of difference for the future pregnancy support of the myometrium. So wherever we can have if you take a large wedge, you have to take a very small wedge if at all you are practicing, and you should undermine and keep those edges overlapping. So normally 0.5 centimeter, 5 millimeter thickness flaps we keep, and it is better to avoid getting into the endometrial cavity opening. So always make sure you don't really enter, because that also adds to the adenomyosis problems. So third case is in early gravida. She has heavy menstrual bleeding and dysmenorrhea. She had a infertility of 2 years, and she underwent an MRG first 1 year back. She came to me. I think she is from the Far East or somewhere. Uterus was almost 16 weeks with one large myoma of 6 centimeter, and there were multiple submucous myomas. We did the hysteroscopy. I think just now we had hysteroscopic myomectomy by Avinvesh. This is innumerable. We could not really count the number of submucous myomas. Rarely we have seen. Definitely we proceeded for the laparoscopy because we knew that the 6 centimeter myoma has to be, intramural myoma has to be taken out. So we enucleated that myoma. And then we found there are multiple small ones popping up. And finally, we decided to open the endometrial cavity. And endometrial cavity, we found the same innumerable one, from small to big ones. Some were 3 centimeter, some were less than that, 1 centimeter. We did not use any energy source because we knew that if you pull out all the myomas with energy source, there will not be any endometrium left behind. Do you agree to this? A laparoscopic myomectomy is better, or I should have pursued the hysteroscopy? Polly, what is your comment?
I would always go for laparoscopic myomectomy in this case, because in that case, you don't injure whenever we do with a hysteroscope, we are doing with a bipolar or monopolar, whatever, the electrosurgery technique, that will lead to adhesions. So when we're doing laparoscopically, we minimize these adhesions, and we can clearly, in a separate layer, we can close the endometrial cavity. And in this case, maybe, sir, we might put a balloon catheter inside so that there is not much of bleeding from the intrauterine myoma beds. And definitely, when there are so many fibroids inside the cavity, laparoscopic myomectomy, this method will be better.
Yeah, I agree with Polly, because if you try to resect this, there will not be any. Will not be able to complete this, yes, because go on coming, and I think the final count was 46 or something. You could actually, once you open the cavity, you could see it better.
Yes.
And many of them were really submucous. And whenever the visibility was poor, we injected dilute vasopressin. I normally inject vasopressin for all my myomectomies, but I use only till it blanches.
Yes.
So once the effect is gone, I repeat the same dose. I normally dilute 20 units into 200 ml, and there will be sufficient volume kept. And I think we are removing the last bit of myomas. Majority, we could pull it out. As you said, identifying and suturing without getting into the cavity is the main key for this. You suggested you put a Foley's catheter now or before that?
No,
after surgery.
After surgery.
After surgery.
After
How do you really safeguard this endometrium? Because it's very difficult to identify where exactly is the limit of myometrium, and any suggestions you can give?
So good visualization when we are doing the laparoscopy, and not using any energy source. Basically, that will help us to safeguard this endometrium. And we don't touch when we are stitching. We normally stitch the endometrial layer in a separate stitch, and then we oppose the thing. And we can put methylene blue also, sir, through a Foley's catheter, just to check how much endometrium, where is the endometrium, that way we can safeguard.
I think that's a good point. Many a time, in this case, it may not really work, but majority of the cases when you put inject the dilute methylene blue,
Yes.
Even during dissection, you can actually stain the endometrium properly so that before actually damaging the endometrium, you may be able to see the endometrium.
Yes,
and
sir.
as you said, clearly visualizing at this point when you take the bites, I normally avoid the endometrium, just take the myometrium because endometrium actually doesn't hold unless you take myometrium. So we normally do. And this patient, after 2 months, we asked her to come and we performed hysteroscopy. We found there are some amount of adhesions which we expected. So I definitely advised them to come. And there were 2 more myomas in the cervical canal. So we released these adhesions with scissors.
Yes, the cold scissors are the best for this.
And it was not a very difficult one. So when you remove, now the adhesions are removed and the myoma could be very easily
Taken out.
Actually, I'm using a smaller 18-point French, 0.5 French resectoscope, especially when you have a smaller myomas. And it's important to remove it completely. And this is the point. And actually, she conceived. We asked her to conceive after 2 months, and then she has a baby now, 3-year-old.
Wonderful.
Sir, are you preferring to put a Foley's catheter in intrauterine cavity?
In this case, I think I did not. We have tried the Foley's catheter in intrauterine adhesions. What is your experience? What do you think about it?
Sir, we regularly keep intrauterine catheters and also put a patient on estrogen.
How many days the Foley's catheter you keep?
Sir, only for 3 to 5 days.
Because many a time it comes out. I don't know whether it really helps. Occasionally, I found if you put the Foley's catheter, there is some pent-up bloody solution inside, and when we remove the type of discharge it comes, I'm not happy whether it's slightly infected or something. Okay. So it's a good option, but it should not really obstruct the cervical canal if you do that, because we know that there is blood fluid inside the uterine cavity. In this case, we did not. And the fourth case is a 28-year-old with severe dysmenorrhea, and she has actually a doctor, unmarried doctor, and she underwent a laparoscopic myomectomy 3 years back before coming to me. They had already removed 5 myomas, and there was a right broad ligament myoma which they could not remove. So the ultrasound, we examined her. It's almost 18 to 20 week size. Ultrasound showed multiple myomas. Largest was 12.1 centimeter. We performed the laparoscopy. You can see a right broad ligament more from the lower. So we thought it's a cakewalk. We cut the round ligament. We injected vasopressin and we tried to enucleate. The myoma screw is slipping, so we thought a tenaculum will do. We hold on. Once you try to pull on the myoma, again it's cut through. And it was bleeding. So we really got frustrated, and we had experience. Actually, I had published my 10 years experience of doing myomectomy and unexpected malignancies. We had 6 cases. So we thought this type of degeneration is compatible with probably malignancy. And my anesthetist said, don't do this procedure. So I thought we'll take a biopsy. Then I thought at least we should take a big chunk of tissue. Otherwise, the biopsy will come out without any definite opinion. We knew that it's going to be difficult to suture the myoma, actually, not the myometrium, but we could actually, and the provisional diagnosis was TUM. Then we sent the biopsy to another center for second opinion, because this is a very difficult diagnosis, whether STUMP or malignancy, because it just a few more number of mitosis or nuclear TPM that makes the diagnosis into a leiomyosarcoma. So the final diagnosis said it's mitotically active leiomyoma. We sent her back to her place, and we were wondering what to do. So what is your opinion, Amit? What should we do?
Myomectomy, laparoscopic myomectomy.
You should attempt again myomectomy, laparoscopically, laparotomy. What is your choice?
Laparoscopically first.
Laparoscopically.
Yes.
But what strategy will make it more? It's quite big one, no? 112, 19 centimeter, and once. Even with our experience, we really was fumbling at this point.
First to ligate the uterine site the origin, ligate the uterine site the origin, and then proceed for the myomectomy.
So try for uterine artery ligation.
Yes.
Oh.
So maybe, sir, can I say?
Pardon?
If we give some GnRH analog before going for the procedure, a little bit, maybe it will reduce and vasopressin nicely and ligate the uterine artery, definitely. All the three might help us prevent the bleeding.
I hope she might have a lot of the GnRH, because it's already friable. So you will not be able to make such a 20 weeks uterus into much difference you cannot make. Definitely you need some combination of uterine artery or vasopressin combination or whatever method we should use. So definitely we again started. There were some small bowel additions at the previous scar where we here operated. So definitely we, instead of uterine artery, I thought internal iliac artery will be much better in this case, because uterine artery is quite high. Ureter is also, your visibility approach to that area is difficult. So I thought of doing internal iliac ligation. We were a little cautious because we knew that such a large fibroid, there will be a lot of vascularity and you can get into trouble. So we had not done many internal iliac ligations, but this case we had did not have any other option. So we identified the junction of the common iliac, and we tried to move more proximally from the junction to avoid injury to the posterior branches. But it was comparatively straightforward, and we applied Hemolock. This case, we had taken permission for doing the adnexectomy because we knew that we cannot actually hold the myoma. If we can hold the myoma, we can pull it out. So I knew that it won't be able to do the myomectomy. And this is the left side. You can see the ureter crossing the external iliac. Normally, the left ureter will be a little more medial. The same internal iliac was identified. You should avoid damage to the veins. That's the main critical point in this case. We can see the vein now. We are separating it and lifting it up and applying the hemlock. Actually, there was no clear demarcation between the myoma and the uterus. So we have to a little bit of cutting through at the fundal region. But towards the lower end, it was quite easily enucleable. We also looked at the cervical canal, whether we had damaged the cervical canal, and we found it was not damaged during the enucleation. Although there was a amount of bleeding, it was acceptable amount of bleeding. We had removed along with the right adnexa because we thought otherwise we won't be able to, because she has undergone third surgery for removing the same myoma.
So what about the ureter? Ureter was very close to it, isn't it?
Yes, the ureter was lateralized during this time. Now the round ligaments are being approximated.
Wonderful, sir.
So the final diagnosis was again, it was not STUM. They confirmed that it's the mitotically active cellular myoma. I was looking back, I was wondering whether we should have done the right adnexectomy. What is your opinion? Amit?
As tissue is very friable, I also do the same thing.
Adnexectomy, no?
Because tissue was so friable, and it's look it's look very difficult to see also to suture for suturing.
Polly, what is your?
Sir, actually, if we got a plane, I don't know. I was not present in the. Definitely, you will be the best person because you did the OT. So, if there was any plane, I would have left the adnexa over there and given an incision just above the ovarian ligament, maybe, just to keep the adnexa, and then we go from there and just bring down the peritoneum, and then maybe. But definitely, I should not comment about it because, and another thing, we try to leave the capsule, but I don't think in this case, but it is mitotically active, you would have any capsule over there. We normally, the broad ligament fibroids, because of the difficulty in stitching, sir, we normally leave a capsule. We do an intracapsular. So in those cases, we might be able to leave. But if it is a mitotically active thing and you don't have any plane, so you should be the best judge, sir, when you're doing it. So that is it.
The reason why I thought of you cannot actually lift it up. You can only push it with some instrument. So since it was actually bulging those area without really cutting the infundibulopelvic pelvic, I won't be able to lift because initially we cut the round ligament and I tried get into that pelvic side wall plane because it's such a huge one. With just pushing with a grasper will not work. You have to completely mobilize more than 50% of the places, then only you will be able to move the myoma. So I felt bad, but I never wanted to fail the third time because she has come all the way and put a lot of and I want to avoid a laparotomy also. But laparotomy also will not make much difference, because this type of hemostasis in laparotomy will not be that easy sometimes. Here actually you can go to every place and achieve hemostasis all the feeding vessels. And definitely there was no cleavage between the myometrium and the myoma, so I have to cut through. But she's doing well, and this was one tough case where I postponed my surgery for the second time. My last case, 30-year-old Nalli Gravida, married life 7 years. They're actually doctors. They were, I think, doing post-graduation and other things. And since last 2 months, they were trying for pregnancy. And they did a scan and came with the report of right ovarian cyst, 7.3 to 5.6, and there was another smaller cyst. I did hysteroscopy. This all must be very familiar to you, very uncommon for me. What is the diagnosis, Amit?
It looks like a tuberculosis.
Pardon?
Looks like a tuberculosis.
Yes. I see only 1 or 2 cases in a year. You must be seeing many cases. So we did not make a diagnosis of this preoperatively because it's very uncommon in my practice. And being a doctor, and the cyst is this one. It's actually an encysted fluid collection. We separated the tube. My question is, I had not taken permission for salpingectomy, only for cystectomy. When you come across, will you do a salpingectomy in this case?
No, sir. If there is, we have not taken a consent. I'm not going to do salpingectomy because I have not taken a consent. We faced the same problem in one case when I was operating in Mumbai, and the patient came from down to from Australia in Cloud9 Hospital there, and we had not taken consent, and we found a similar picture, and we just counseled to her husband, and and we have given an option that second surgery, and in that after the taking treatment, if it comes TB positive, then we will do then we will we have planned for the medical management, and after that after 6 months we have planned for the second surgery to look for the other things, and to do the salpingectomy or just tubal delinking. We had given option to them after that, but we had not done salpingectomy.
What about Polly? What will you do?
Sir, we would definitely take biopsies from all the places and try to make the anatomy as better as possible. Do the cystectomy. This is a pus coming out, and definitely not salpingectomy. We might clip the tubes sometimes, but it all depends. We normally bring the husband inside and show them this is a thing, and but actually with the husband's consent, we cannot do the salpingectomy. So that is a difficulty in these cases. And you have seen the Peutz-Curtis syndrome. In the liver bed also you have adhesions.
Adhesions.
So yes, adhesions all over.
And she never had any symptoms. So actually, as you said, I should have taken only biopsy. But I discussed with the husband. Then husband said he's also doctor. He said, I said definitely there is a lot of KCT material inside. Then they agreed. Husband agreed. As you said, it's not valid. But in our Indian circumstances, sometimes if the family believes or the husband says, then we agree. Definitely, medical legally you are not protected.
Yes.
So I performed a salpingectomy and then put her You saw that the endometrium was also positive. How long you take to perform the IVF?
Sir, at
How
least
long you wait
So after completing the AKT only.
after completing 6 months?
6 months,
Yes.
minimum 6 months.
Should we do a repeat hysteroscopy or?
So actually, we send the after the patient came positive, we send the patient to the specialist for AKT, and if they suggest for 6 months or 9 months, then we do sonography, and if need arise, then we do hysteroscopy.
Okay. Because
If there is no any endometrial, no, if there is no any good endometrium on this UAG, then we will do hysteroscopy. If it shows good endometrium, good zoning and everything, then we we in our center we don't do this.
okay. Here there was no additions. Actually, the inflamed endometrium we can see actually. So most likely she will have a good endometrial recovery, I think so. I think this is my last case. Any comments or any questions from the audience or anything we can discuss?
Sir, it was wonderful, excellent videos and excellent discussion. Really grateful to the organizers and to you to be a part of this program. Thank you so much, sir.
Sir, recently I have
Although we had only yes, Amit.
So recently I have faced one case. Actually, patient is postmenopausal, and she is 55 years old, and she came to clinic that she has only a complaint of foul smelling discharge. On post speculum examination, I found that there is some discharge from the intrauterine cavity, so we sent her for the ultrasonography, and ultrasonography report came as a osseous metaplasia. But on hysteroscopy, there is no any signs of this metaplasia. So I take a minimal bites of endometrium, as she has a very atrophic endometrium, and that report came as a cartilaginous endometritis.
Which one?
Cartilaginous endometritis. Also, I talked with the pathologist, histopathologist. He told me this is actually I seen this first time only, uh, and yet report is with pathologist. I just talked with him yesterday. How to proceed in this case, sir? How to
But there was no evidence of bony tissues in the cavity,
No, sir. No any. But he told that this is very rare, and it comes from smooth muscle, and it's present inside the this myometrium. And
Endometrium was very thin. Endometrium was, what was the endometrium? Was it thin or?
no, sir. It's 7.2 around 7.2. But patient is postmenopausal,
Uh,
and on UAG there is proper calcified area.
We have actually,
And
I had a few cases of this osseous metaplasia, but they were all actually bones in bony like particles, fragments inside. But I have not seen whether without having a bony tissue.
We didn't find any single piece.
I think then the prognosis may not be very bad if the endometrium is growing normally. There must not be any definite treatment available because we don't know the pathological thing.
And we also found she has one fibroid, small fibroid. But I know she is a postmenopausal and she don't have any complaint. And in 2017, I had done histoscopy for postmenopausal bleed. She was before that she was just she has stopped her menses 1.5 years back. In 2017, in her we sent that endometrium report was atrophic endometritis only, and nothing but that. And on perspective, I didn't found any before surgery. I didn't found any bleeding there.
She's for any infertility treatment or
No, no, no,
just
sir. No, sir. She's my regular patient. She's for only foul smelling discharge. She came for foul smelling discharge.
I think what we can do is maximum is still some empirical treatment for chronic endometritis or something like that. Only empirical treatment is available because we don't have any definite diagnosis. But definitely there is no potential for malignancy, and also we can actually ignore that potential.
It might be some degenerated fibroids embedded. It could be some small degenerated fibroids, maybe. But we have never seen cartilaginous report in the fibroid.
He just yesterday night only he talked with me that it shows some cartilaginous. I will give you in 2 days final report. And he was asking for the UAG pictures and everything. Yesterday night only I shared with him.
I had long back a case of endometrioma with calcified cyst lining. It was like our eggshells, it get crackled, and it was difficulty in, I used a mosulator to cut it into small pieces. So this calcification all possible in any type of chronic lesions, chronic inflammatory conditions. It need not be infection itself. Any chronic inflammation can lead to, because that case of endometrioma was a long-standing one, but there was no evidence of infection or malignancy in that case. So if there are no more questions, I thank, although we had one more panelist, I thank Polly and Amit for participating and making it lively. And I thank the organizers for giving me this opportunity.
Thank you,
Thank
sir.
you once again.
So much, sir.
Thank you, sir. Thank you, Polly ma'am. And thank you all organizers. Thank you so much.
Okay, thank you. So now we are ending the session. Good morning, sir. Hello, sir. Yes, sir. It is perfectly visual, sir.
Thank you. This will open exactly at 12 o'clock, is it?
Yes, yes. Every audition is going on
Okay.
in
And
hallway. So after finishing the audition, we will start the session.
thank you. Thank you.
Hello, good afternoon, ma'am. Ma'am, please unmute yourself.
I don't go yet, right?
Yes, ma'am. Ma'am, actually, right now it's oration going on in hall A. After the oration, we will start the session. Ma'am.
Trying to change the picture.
You can.
If I-
Before joining, you will have to log in with zoom.us and change in profile.
Yeah. Hi, Dr. Sunita.
हेलो कैसे हो?
मैं ठीक हूँ, आप बताइए। काफी बिजी चल रहे हैं आप।
हाँ थोड़ी बिजी हूँ।
अच्छा।
चल रहा है।
हाँ, पर अच्छा रहा ऐसा सुनते हैं सारा। मैं कल नहीं अटेंड कर पाई, पर आज रहूंगी इसके बाद सारा
ओके अभी तो वहाँ चल रहा है, ऑडिशन चल रहा है, तो लेट इट बी फिनिश्ड तब स्टार्ट कर।
जी जी ओके थैंक यू।
Santanu sir, can you move the camera a little bit down? Little bit more. Now it's better.
Shantanu, good afternoon. Unmute.
Yeah. Good afternoon.
You are from SRM University?
I am from IIT Kharagpur.
Kharagpur. Okay. So you have done some work with SRM University?
Not really.
Okay.
Good morning, sir.
Yeah, good morning. Good morning. Yeah.
Morning.
So, how are you doing, ma'am?
I'm fine
Yeah.
and eager to listen from your experience. What are you doing? Huh?
Yeah. I mean,
Atul has assisted you, na?
pardon?
Atul.
Yeah. I have actually uploaded the talk actually. So I have recorded the talk and I have uploaded.
Okay.
Yeah.
How far the work is done?
Yeah, it's going quite well now. Actually, we had, as you know, the pandemic, and second is the shifting of the department. So that was the major issue. But now we are set. So now Atul is doing it full swing. So that's the main thing.
Just one week back, he has taken one uterus.
Yeah.
So already completed that part, na?
It is going on.
Okay.
Yeah.
Thank you. One audition is going on. That's why it is delayed for some time.
Yeah.
Okay. Thank you.
Yeah.
Swati ma'am. Hello.
Yes, I'm here.
Yes. So I'm giving the countdown from 5 to 1.
Okay,
Then you can start.
sure.
Okay, ma'am. So okay. 5, 4, 3, 2, 1. We are live, ma'am. You can start.
Good afternoon, everyone. And now, taking the day forward, let's start our next session of the day. And for that, I'd like to introduce the chairperson of the session, Dr. Sunita Sharma. Just a few words about ma'am. Dr. Sharma is a senior consultant in reproductive medicine and surgery at the Institute of Reproductive Medicine, Kolkata. Over 15 years of experience in reproductive medicine and ART, and faculty of FNB courses in reproductive medicine. She has a research interest in minimal stimulation IVF and biomarkers of endometrial receptivity, new approaches towards pain and infertility management in women suffering from endometriosis and adenomyosis, treatment of cervical atresia, and creation of new cervix using neocervix using regenerative medicine approach. She has 12 research papers in International Journal of Repute, 11 book chapters, present regularly at ESHRE and ASRM, speaks and faculty of various national and international conferences and symposia. She has won the prestigious Robert J. Edward Prize paper for the best paper published in RBMO in 2019, in collaboration with COGI 2020 for the paper entitled Does Presence of Adenomyosis Affect Reproductive Outcome in IVF Cycle? A retrospective analysis of 973 patients. Madam, the stage is all yours. Kindly introduce the speakers and take it over from here. Thank you.
Thank you, Swati. Good afternoon, everyone. I welcome all you to the session with three important topics like fertility preservation, engineering of reproductive organs, and Cochrane reviews in clinical practice. So it is my pleasure and honor to introduce Dr. P.M. Gopinath. Sir, Dr. P.M. Gopinath is the Director and Senior Consultant, Institute of OBG and IVF in prestigious SRM Institute for Medical Science, Vadappa, Chennai. He is President, Fertility Preservation Society, President, Society of Vaginal Surgeon, TN Branch, Member of International Fertility Preservation, Founder Secretary of IFS Tamil Nadu, Chapter, Member of IABA, ISAR, ASRE. He's invited faculty in various national and international specialty training in fertility preservation, Seva Medical Center, Israel. He is former professor of ONG Madras Medical College, and he was a past president of OGSSI. Sir, you are talking about fertility preservation challenges. I welcome Dr. P.M. Gopinath.
Good afternoon, Chairperson, and then dear organizers. Thank you very much for inviting me to give a talk on these challenges in fertility preservation. If you see the incidence of cancer in young women. For example, in 15 to 19 years, you see the burden, and then you see that burden in 20 to 29. We have more and more cases. As we are an undergraduate student, we used to run from ward to ward to see a patient of cancer. Today, we have almost every one case of cancer is there. Is there an increased incidence of cancer in the adolescent and young female, or more and more diagnosis being given? There is improvements in the treatment, increase in the survival rates, requires both quantity and quality of life. So therefore, the fertility options are being discussed. I don't have to discuss about the details to this August audience on the effect of chemotherapy. And if you see the slide on top, the first diagram shows there is a balanced activation by a PIK pathway, and then there is a suppression for further thing. Whereas what happens is when the patient is undergoing a chemotherapy, there is an activation, the accelerated activation, more and more mature oocytes are coming and getting destroyed, but there is loss of suppression again more and more. There is what we call it as a complete burnout phenomenon. So again, looking at the radiotherapy, there's a lot of damages either directly to the ovary or to the HPO axis. This is mainly a dose dependent, age dependent, and radiation field dependent. What does it do? It could also affect the uterine blood flow, impaired flow, endometrial damage, small uterine volume. There is an increased incidence of miscarriages there. What are the challenges we have in fertility preservation? One is it has to be a team approach. The oncologist, both medical and surgical and radiation, pediatric oncologist, along with the counselors, has to work with an ART team together, and then they should see the same page as the other person sees them. If you, for example, this is the flow chart, I can just show you. So if there is a decision of a cancer, what actually we try to do, we just see the treatment plan. The moment you have a treatment plan, look at the axis of fertility risk based on the treatment. If there is a risk based, then inform the risk, document it, and then refer to the fertility preservation. If there is no risk, there again have a discussion, document it, and then continue your treatment. So this is what normally is recommended for all the patients. And again, one of the challenges is awareness of the fertility preservation to the onco team. The fertility preservation is a new entrant. Our society was formed in about 2014. We have hardly about 200 members so far. We do conduct annual conferences, regional conferences, have a newsletter, an oncofertility journal. Still, we are not able to cover the needy spectrum. This, you will understand what will be the extent to which the onco team will be involved. How does that acceptance of the fertility preservation by the team? In view of the increase in survivals, there is a large population of young cancer survivors. There is a need for the quality of a life, but also the quantity. There is a question of fertility preservation. Do they discuss the options or refer for fertility preservation? Or do they fear that there will be a delay in the initiation of the cancer therapy, thereby they rush directly there? How does the patient accept the fertility preservation? They are baffled with the diagnosis of cancer. They are in a state of a crude shock. They look for the survival as the endpoint, primary endpoint. They are burdened with the cost of the cancer treatment. Fertility preservation is yet to be covered by most of the insurance there. What about the financial issues? The cost of the cancer treatment is prohibitive today. Additional burden of expensive chemotherapy. The more advanced radiotherapy demands a large purse. Cost of the fertility treatment is an additional burden. The cost of the long-time storing of the gametes is again another higher burden. So another challenge here is the availability of the time. The type of a cancer is very crucial. Once when they're diagnosed, certain cancer, there is no time given for a standard fertility preservation. And the surgery or chemotherapy has to be started immediately, and there is no time for the ovarian stimulation and OPU. Some tumors behave very badly with the increase in estrogen, which occurs with the ovarian stimulation. There again, the age is a challenge. In a male, it can be a post-pubertal, very easy. You can collect the sperm and then preserve it. And if it happens to be a prepubertal, we just have to try, encourage, ask them to just give a sample, give a stimulation, try to talk to the peers, and then use a small vibrators and then try. All this raises a lot of ethical questions. The same way, if it is a female, if it is a prepubertal, there is the question of all the other newer developments about which I'll be able to explain it in a couple of slides. Post-pubertal, and if she is an unmarried, their chances are limited. And post-pubertal, if it is married, fine, embryo transfer is there. So availability of the partner is again a very crucial challenge. If the patient is pre-pubertal, then there is no question. And if the patient is a post-pubertal with no partner, then you have to choose a oocyte cryopreservation. If the patient is a post-pubertal with partner, then you can go in for embryo cryopreservation. The question of using a chemotherapy, when you are undergoing a chemotherapy, there is a possibility you can use GnRH analogs to preserve them. So this is in practice only in selected places, but of course you cannot go by a standard thing, and you will see that there is a lot of randomized data is not available for the phase 2 trials there. There are some other pharmacological agents like apoptosis inhibition by a sphingosine 1-phosphate, and here when it is injected into the ovarian bursa of a rat and just subject to the radiation, they seems to protect the ovary. But however, this work is yet to be translated into the clinical. The next option comes into the ovarian cryopreservation, the whole ovary, and there are embryos was created from the oocytes and retrieved from the subcutaneous transplanted ovarian tissue. 2 live births has been reported after orthotic trial. Then comes the oocyte cryopreservation. It was difficult because they were using a slow freezing. M2 oocytes, they have a lot of issues like depolymerized mitotic spindle, causing an aneuploidy and hardening of the zona, which was a barrier to the fertilization. And these are all some of the challenges we had it with the oocyte cryopreservation. But today, when you look into the vitrification, it is no more an experimental. It has become a standard procedure of the guideline, which has been given by ESHRE and ASRM. So the vitrification does not affect the oocyte quality, which has been highlighted by several papers there. When you have no partner, they have been putting them onto the ovarian tissue cryopreservation. Patient can be prepubertal, do not need a sperm. It can be quickly done. Even in a post-pubertal where you have to rush for the treatment, you can quickly take out the ovarian tissue, we can do it. And there is a potential hazard for reintroduction of the malignant cells at the reimplantation. And it was considered experimental, but declared as a standard care in ASRM 2020. And as of today, we have more than about 150 babies have been born all over the world. Here, and it is normally taken into only a slow freezing. We have difficulties in just taking it out. And then they have just tried it and then implanted it and then seen it. About 4 to 5 months is necessary for a rise of estradiol and then reduction of FSH level, which was published by Silver et al. So either by open lab or a lab, a small tissues have been taken here. And then you just see that the oocytes are present only, the follicles are present close to the cortex. So it will be shaved and made it thin strips like this. And it will be stored in a liquid nitrogen. You can take it out and then put it back by making a small tunneling incision on the subcortical area with which you will be able to do that. As of today, it's about more than 150 babies have been born. There are some long-term issues with the storage there. It has to be maintained until the cancer treatment is complete. They won't be able to come back within 2 or 3 cycles. Maybe for a few years might have to do. The cost of the storage has to be subsidized to this fertility preservation people. We also look into the reimplantation of the malignant cells. It's a big time worry. It may do more harm to the patient. EP team has to choose the correct procedure and with appropriate safe techniques there. You can do it small by bioincubators. One is by HPE examination, but putting into a mouse embryos, the bioincubators, we can just put it in a guinea pig into the peritoneal surface and see whether you are getting into a malignancy, and then do that. And then alternatively, these are all the PCR analysis, and then you can just use a classical PCR, and you can use a matrix laser assisted, or we have to just go for a P53 mutation and then see to that we do not transfer a malignant cell. Ultimately, what is your wish list? A better education of the oncology team and healthcare providers is very, very important. They have to discuss the importance of the fertility preservation there. And then the survivor group has to be there to motivate them. And there has to be enough funding for the fertility preservation. More amount of research is needed in the oncofertility. Now, let us see what are all the barriers or the challenges there. One is the safety concern. We have been using hormones for ovarian hyperstimulation, and it should not produce hyperestrogenic environment. Nowadays, we just started using letrozole to produce the supraphysiological levels of estradiol during the stimulation. And we also don't wait for the stimulation to wait and for the menses to start. We do have the luteal phase stimulations, and what we call it as a double stimulations in a make sure that the time is not taken, and there is no treatment delay with this newer technologies in the stimulation protocols. There are some lot of ethical concern treatment for the minors. When it was experimental, are we subjected to them? So this was a question which was just brought about by a lot of ethical things. The same way, collecting a semen sample from a young boy who doesn't know about the masturbation is again very important thing. So alternatively, we have to just go for a testicular tissue grafting. So if it is better to just get it, so that is the reason we have just started talking to the peers to motivate the boys to use small stimulators and then vibrators and then try to get the sample. So is it ethical? Is it truly acceptable by all? Says the question. Then there is some logistical issues, lack of access to the appropriate fertility centers. So all the oncology team should have a coordination with the fertility preservation units, and then they should have a counseling, and they should put forward all the possibilities to the patient before they start the treatment. So it is our duty to explain to the couple, to the patient, whether it is married or not married or younger woman, to their family, about what are all the prospects of fertility preservation available, and then what are all the hazards of continuing the treatment with the oncofertility. And then this is very important that all the discussion has to be made, and then it should be documented. About the financial issues, there is a disease often strains the patients, definitely. And there is family finances is very, very important. Fertility preservation, again, is quite an expensive. If you're going to go in for a stimulation, do a thing, it is equivalent to that of doing an IVF. The same way, if you're going to take an ovarian cortex and then do a cryopreservation, preserve it for a longer years of 2 years or 3 years, and then you really don't know what is the outcome, but still you have to keep paying the money and then doing it. So it is going to be quite expensive, and these are all the barriers for the fertility preservation. So to summarize, we have to have an adequate counseling. That is number one. Number two, there has to be a good interaction in the oncofertility team. So once when the diagnosis is made, we should be able to discuss what are all the probabilities, either a chemotherapy or a radiotherapy, what is the extent to which you are just going to do it, what is the impact of the treatment on fertility, and then this has to be discussed, and then suitable. For example, a young girl coming with for a fertility preservation, then obviously ovarian cortex cryopreservation tissue, the OTC has to be offered. If she is younger and she is not married, if she is post-pubertal, then you have to offer them oocyte cryopreservation. And if she is married with a partner, then we have to just give them an embryo cryopreservation. For example, if the patient with the breast cancer, where the chemotherapy says that he cannot wait for the stimulation, then you can take the ovarian tissue cryopreservation on the patient, in spite of she being a post-pubertal, in spite of the partner being available. Anatomical fixes has to be just taken into consideration by both laparoscopy or by open surgery before you put the patient to the radiation into the field. There are some ovarian suppression. It's still in an experimental stage. It is going on. Cryopreservation of the embryos is the gold standard, and cryopreservation in oocytes is no more an experimental. It is a standard care. Cryopreservation of the ovarian tissue, even though the ASRM is accepted, it is still an experimental in our part of the world. Not everybody has standardized the technique. And even in our center, we have taken a lot of tissues and preserved it, but still they have not come back for the harvesting there. So oocyte donation and gestational surrogacy should be kept as the last option for them to do it. Thank you very much for your patient listening. I encourage all of you to become members of the Fertility Preservation Society of India. The numbers are given here. The email is very simple, fertilitypreservationsociety@gmail.com. It is one-time payment where you will be a life member, support this society, and then make sure that the entire ONCO team is benefited by our endeavors with the society. Thank you very much for your patient listening.
Thank you, sir, for your nice and crisp presentation. There's one practical question, sir. In our OPD, we have many non-oncological patients, non-oncological disease like endometriosis, like autoimmune disease, which as ages, there is a decline in fertility. So can we counsel these type of women for the fertility preservation? What is your
Definitely. See, on a non-oncological patterns, if you see, for example, I have a patient who is a second gravida. She's got a normal conception first child, and second time she comes, when you tried, she has got a very, very poor AMH. So when we look into the history, her mother has attained menopause at 38, her elder sister has attained menopause at 37. So in that case scenario, if I have known it earlier, I would have encouraged her, or at least I should have done an embryo cryopreservation. So we have to look into the details, both for oncological and non-oncological. If the partner is available, do an embryo cryopreservation. If the partner is not available, please go ahead and do ovarian tissue or the oocyte cryopreservation.
Sir, what about the adolescent women who have a severe endometriosis? As we know, there are many adolescent women coming for the severe endometriosis.
Yes.
And then
yes. So we have taken some tissues and harvested, but we had to share our experience on reimplantation. But we can do it. But only thing is, if you are doing a surgery on the ovary, either by a laparoscopy or an open surgery, we can explain the prospect to them. Just take out the cortex, thin the cortex into small strips, and you can preserve it. At the end of the treatment, we will decide what is the left out ovarian reserve, whether we are able to stimulate it, or if you are not able to stimulate it, you can just go in for a transplantation of this cortical tissues.
Thank you, sir.
Thank you.
Thank you so much for your valuable opinion. Now I would like to invite Dr. Shantanu Dhara. Dr. Shantanu Dhara has received doctoral degree from Material Science Center, IIT Kharagpur, subsequently earned EPSRC Fellowship UK for working as a research fellow in the University of Birmingham and research assistant in the University of Bristol. After working for a very short period as scientist C in the ceramics composite group, DMRL Hyderabad, he joined School of Medical Science and Technology, IIT Kharagpur in the year 2007. Dr. Dhara is currently working as a professor in the School of Medical Science and Technology, IIT Kharagpur. He has established biomaterials and tissue engineering lab in the school with the vision of product development research based on fundamental understanding of cell-material interaction. He has published about 160 research articles and filed 20 patents. He worked for DRDO Hyderabad as scientist C, working as a professor at School of Medical Science and Technology, IIT Kharagpur, area of synthesis, fabrication, surface modification, biomimetic synthesis and tissue engineering, wound research, bone ceramics fabrication, polymeric fibrous scaffold, skin tissue engineering, published 160 articles in peer-reviewed journal, received IIM Ahmedabad Silver Medal for Technology Development, filed 20 patents. Dr. Dhara will speak on engineering of reproductive organ.
So this is Santanu from IIT Kharagpur. So I'm working as a professor at the School of Medical Science and Technology. So we have formed a group, Biomaterials and Tissue Engineering, in the year 2007. Since then, we are working on different approaches towards tissue engineering and the restoration of the tissues and the biomedical devices by different approaches. So currently, title of my talk is Bioengineering of Reproductive Organs, Regeneration by Tissue Engineering Approaches. So as you see here, the fundamentals of tissue engineering, the slides which is showing that, so you need to have a cells, scaffolds, and different factors like cytokines, chemokines, maybe different proteins, maybe growth factors which are required maybe for cell proliferation, cell differentiation, as well as cellular organization to work in a synchrony to form the tissues from the cells. So there are different group of people worldwide who are working on this. I think some of the pioneering work from Anthony Atala, Robert Langer, David Mooney, and many others. So as you see here, utilizing the tissue engineering approaches now in recent time, people are working on stem cells, differentiations, induced pluripotent stem cells, as well as different novel chemistries they are utilizing, growth factors, different factors, exploring the chemistries. They are also exploring different biochemical cues, electrical stimuli, and so on to differentiate the cells and the tissues to form. So here different approaches are used for forming the scaffolds, for example, self-assembly, 3D printing, decellularization of organ, and again recellularization of the organ. Even the organs are used, decellularized and crushed into the hydrogel and printed into the tissues. Sometimes we use the smaller molecules, proteins, and they are self-assembled to form different tissues. So as you see here, so Anthony Atala has published this work. Anthony Atala has published this work in 2020. And this is basically a review article. And here you can see there are different organs. For example, you can see the lungs, heart, kidney. So different organs are actually explored to decellularize and recellularize. It is because, sometimes because of the organ failure, explore different kind of treatment options. However, at the extreme stages, because of the failure of the organs, so people explore methods like transplantation. And even then, because of problem associated with immunogenic responses, so there are novel approaches which is coming up in recent time. I think Weiss Lab is one of the laboratory where extensively they are working on decellularization, and because of decellularization, the immunogenic responses would be minimized. But still there would be some chances of immunogenic responses. So need to work on different immunosuppressive drugs. However, you can see here the heart tissues which are decellularized, and this decellularized heart can be further decellularized to utilize directly using the host cells to form a tissue analog structure, and that can be perhaps transplanted into the patients. So here you can see the entire arms, like you can see the arm including the bone, the blood vessels, muscles, and the entire tissues are decellularized. So you can see that, so this decellularized tissue can be further recellularized, which is of course challenging, but can be explored to see whether it can work like a tissue. Okay, and here I would like to mention here that so bioreactor can play a major role for recellularization and to work in a synchrony, to work in an environment which is similar to the native environment. So, so now next slide, I'm talking about reproductive organs and bioengineering needs and progresses. The female reproductive system is comprised of ovaries, fallopian tubes, uterus, vagina, and external genitalia. So the female reproductive system is complex. Dysfunction can occur in several organs and tissues, resulting in infertility as well as hormonal imbalance. So female reproductive dysfunction include ovarian cancer, ovarian insufficiency, polycystic ovarian syndrome, endometriosis, fallopian tube occlusion, and other related anomalies. So bioengineering strategies can be classified into two broad categories, like transplantation of fresh or cryopreserved organ, or tissue engineering approaches can be utilized to combine the cells, growth factors, and biomaterials to make tissues very similar to the body, and then it can be regenerate or repair. Maybe you can explore different type of bioreactors for such applications and implications. Okay, so bioengineering of uterus. Uterus is the largest organ in the female reproductive tract. 3 layers, perimetrium on the periphery and myometrium in the middle, and endometrium towards the lumen of the uterine cavity. So endometrium has a high regenerative capacity, actively dividing endometrial cells and surrounding knees is associated with endometriosis, endometrial cancer, and dysfunctional uterus. So gestational surrogacy, issues like personal, religious, ethical, and legal factors is also important. An allogenic uterus transplantation study, as published by Branstorm et al., reported that a successful live birth possible so now not appropriate for every patient. Lifelong immune suppressive treatment is essential for that. So as you see here, bioengineering approaches for uterus regeneration. So there are different approaches like cell therapy, scaffolds, exploring scaffolds for the application. Scaffolds can be made by bioprinting, or tissue can be transplanted directly. Herein, scaffolds can be made, and with the help of, so tissue or organ can be used and decellularized to make the only extracellular matrix, and which can be further recellularized, or cells can be isolated from the tissues, can be expanded and then seeded on the scaffolds or seeded on the decellularized scaffolds to make the tissue analog structure. So herein we can use the monomer, polymerized and cross-linked, or maybe we can use certain polymers which can be modified, which can be made bioactive by grafting with the different kind of bioactive factors. We can make a composite, and then we can also again take the help of the cells which can be seeded on the side, or we can take a defective uterus which can be further decellularized and then can be recellularized to make a tissue analog structure. So of course different cells like mesenchymal stem cells, induced pluripotent stem cells, uterine cells, etc. Can be explored to seeded on the scaffold and can be further modified or differentiated by utilizing different growth factors or different external stimuli. So for decellularization, so basically decellularized extracellular matrices or scaffolds are typically genogenic, and these scaffolds, because it's really difficult sometimes to get the human tissues, and of course, so that is why we rely on different type of animal-based tissues, and these scaffolds do not elicit an adverse innate or adaptive immune response. The whole organ decellularization has been achieved, for example, kidney, lungs, heart, liver, pancreas, arms, uterus, or ovaries. And decellularization actually checkpoint is like we should have less than 50 nanogram double-stranded DNA per milligram of extracellular matrix, dry weight basis. Similarly, less than 100 base pair DNA fragment length should be present, and no visible nuclear material should be there. So those are confirmed by different running the gel for the tissues, or maybe by different biochemical assays. For example, we can use the Duffy staining and do kind of imaging, histochemical and immunohistochemistry analysis. So therefore, to confirm that it does not have enough DNA type of materials. Okay. So here Anthony Atala has a quote on uterus. Unlike any other organs in the body, the woman uses the uterus a very few times in her life, and sometimes not at all. Unfortunately, for many women, the uterus cannot be activated because uterine factor infertility issues, or perhaps some are born without one. So on one treatment solution in uterine transplants, which have just recently become the medical reality, to date, there have been about 70 uterus transplantations far from worldwide. While it is wonderful options for some women, it is major surgery which requires a deceased or living donor, followed by the need to take anti-rejection medications, so immune suppression drugs, so that the body does not reject the organs. So future inclination, the bioengineering approach may provide the regenerative medicine solution to uterine factor infertility. It will allow us to create the uterus for a woman from her own cells combined with biomaterials, eliminating the risk of rejection, need of anti-rejection drugs. So here you can see that Atala's group has very recently reported a tissue-engineered uterus support live birth in rabbit model. So as you can see here, they have a native tissues, and in this native tissues they have made a tubular graft, and this tubular graft is sutured with the tissues, and that graft is actually implanted in the rabbit model, and later on this rabbit has given the birth of the newborn in within the 6 months. So as you can see here, the very clear-cut example where the scaffold was explored to use for the synthetic uterus purpose. Here, for making the scaffold, poly-D-L-lactide glycolide, PLGA basically is a graft polymer coated with polyglycolic, I think block copolymer coated with polyglycolic acid, PGA, was used, and they made into the tubular graft, which was further grafted on the animal model. And so this paper was published in 2020 Nature Biotechnology journal. Okay, so this is showing us that there is a possibility, there is an opportunity. If you can explore, perhaps it is possible also to do the wonderful job even for the human being or for any other mammalians. So towards a bioengineered uterus, bioactive sieve uterus scaffolds are effectively recellularized by enzymatic preconditioning. Matt's Hellstrom group has reported this work. So as you can see here, it's a decellularized sheep uterus scaffold with organized fiber. So this is completely decellularized. After, so you can clearly see the collagen bundles remained intact, and pluripotent cells for recellularization is used. Surface cells density can be seen, and then heterogeneous sheep fetal stem cells isolated from fetus and grown, and sheep fetal stem cells. So basically, so explore to use the fetal stem cells using the neonatal, I think neonatal, and then the cells were expanded and seeded on the decellularized matrices, and then sheep fetal stem cells kept their pluripotency during recellularization. So as you can see, there is the expression of vimentin and smooth muscles actin. So it shows the significant regeneration of the decellularized matrix. So therefore, by preconditioning, so this can be used as a kind of analogous to tissues which can be used as a uterus. Okay. So bioengineering of ovary, the ovary's fundamental role is to produce oocyte and secrete hormones from ovarian follicles, corpus luteum during the ovarian cycle. Approaches for ovary function restoration, the transplantation of partial and whole ovaries that had been cryopreserved before cancer treatment. So this is a new kind of area is coming up, emerging. So it's onco fertility, and so basically prior to the treatment, the organ can be withdrawn, and then it can be cryopreserved, and further after the treatment, when the patient has recovered, it can be further grafted on the side so that it doesn't damage during the treatment, cancer treatment. The generation of ovarian tissue from the stem cells, use of tissue engineering methods to reconstruct ovarian tissues. So autologous transplantation of cryopreserved whole ovary and partial ovarian tissues into the rabbit, monkey and sheep has been already achieved. So in fact, when I was attending a meeting in I think in Austria in 2012, I remember one company from US, they were mentioning that placenta, skin, many other human tissues can be explored. In fact, some of the companies already have shown that decellularized bone, which they are marketing, and decellularized skin is already used in the I think National Burn Center from Mumbai. They are already using this decellularized skin for burn dressing purposes. I think it works really wonderful way. Similarly, placenta can be also explored for diverse applications, including cornea regeneration, for tissue engineering of many other organs, including blood vessels, or even the dressing materials, and so on and so forth. Actually, the placenta has a huge amount of growth factors which can be utilized many different ways for many different tissues, including the placenta has many stem cells that can be also explored for applications. So our group here at School of Medical Science and Technology, they are working on, of course, development of different scaffolds and tissue analog structure, specifically for skin wound healing, dermal wound healing, as well as bone wound healing and cartilage wound healing, mostly. Currently, also we are working on cornea, and also we have removed the what you call genetic materials, and then we have shown how it can be utilized for cartilage healing, bone healing, as well as the wound healing. So silk sponges ornamented with placenta-derived extracellular matrix augmented full thickness cutaneous wound healing by stimulating neovascularization and cellular migration was also shown here. So as you can see here, so we have done some scratch assay, and also we have shown with the CAM assay that how it is promoting the neovascularization. And of course, we have shown that how stratification is happening. As you can see, there is expression of keratin 10.
So therefore, you can see that skin healing also is done quite satisfactorily. So currently, I think our group is also exploring in collaboration with different groups. I think Otul is working on that. So here we are working on development of cervical analog for women and with cervical atresia using tissue engineering approaches. So as you can see here, we have collected the cervix, which was, during the surgery, it was removed. And then we have actually brought from Kolkata, then we have completely decellularized. As you can clearly see, there is intact collagen with a strand, collagen strand, band, you can clearly see. And then histological studies also shows that it is almost free of genetic materials. So therefore, this work can be further carried forward to recellularize and can be made into tissue analog structure. And of course, we are exploring different other way to make a cervical analog tissue structure. So so there are enormous features scope on this. So the whole cervical recellularization could be adapted as a new therapeutic avenue for the cervical atresia patients. So hydrogel based endometrial microtissue analog injection could be developed. Skin decellularization for bone wound healing is already practiced. Also the bone demineralized bone matrix we have explored for bone healing, as well as we have used placental derived material for skin, bone and cartilage healing. So vital organs utilization by this approach could be a life-saving therapy. Genetically modified peaks and their utilization in organ transplantation could be an interesting to adapt therapeutic alternatives. Okay, so with that, I would like to end my lecture. If you have any queries, please let me know. Thank you.
Thank you, Dr. Dhara, for your nice presentation.
Ma'am, your internet connection not stable, so we can't hear you, ma'am.
May soon offer new for patient with end stage.
Ma'am, we cannot hear you properly.
Serious injury. There is one question. Can you hear?
Yes, now it is better. Yes, now
Hello.
it is better. Hello, now it's better, ma'am.
Okay. Thank you, Dr. Dhara, for nice presentation. We hope that regenerative medicine and tissue who have end-stage reproductive failure or serious injury. There is one question from Dr. Ruma. She is asking that when we are implanting the cell on the matrix, so there is the chances of cancerous cell. So is it chances there, and how many? What is the time taken for one organ to develop in the laboratory?
Yeah, I think this is a very kind of important question. So usually by tissue engineering approach, right? So we are not able to grow very big organs because there is issues related to vasculatures. So usually we make the scaffolds, and maybe one dimension is very thin, so that there is no challenges specifically in terms of mass transport. And those organs we actually transplant to the animal model, and then we look at the regeneration aspects. However, to work on a big organ, I think still we have to go a long way.
Thank you, Dr. Dhara, again for your excellent presentation. Our next speaker is Dr. Uma Satvik. Hello.
Has Dr. Ruma Satvik logged in?
I am here, Dr. Swati.
Okay, okay, thank you.
I'm happy to introduce Dr. Ruma Satvik. She's also a good friend of mine. She is a consultant center of IVF and human reproduction at Gangaram Hospital, New Delhi since 2010. She is co-convener in IFS Special Interest Group in Research Methodology. She is teaching faculty and guiding NBE Fellowship in Reproductive Medicine, Amity IFS Fellowship in Reproductive Medicine. She is the reviewer in Journal of Human Reproductive Science. She has special interest in research, ovarian physiology, and unexplained infertility. She has a 10 publication on PubMed and other database. So I'm inviting Ruma to talk on Cochrane reviews and clinical practices.
Thank you, Dr. Sunita. I hope you can see my screen.
Yes, ma'am.
Yes.
So without any much more ado, I'd just like to quickly make a disclaimer here that I'm not one of the people involved in Cochrane reviews or in organizing evidence, in research, but I make this talk as a consumer of research, of a keen observer of how systematic reviews are done. So we do understand that, and all of us are consumers of research in one way or the other. The talk tries to highlight how Cochrane reviews are important to us, how to glean information from them, and also to some extent, what to do when Cochrane reviews don't have the answer. So which begs the question, what are Cochrane reviews? Cochrane, we all know, is this international not-for-profit organization which collects and organizes medical research into easily usable formats, and it collects all of this in its Cochrane library, which the library has basically databases, 3 databases. One is reviews, second is trials, and third is Cochrane clinical answers. Now, reviews are what will generate a synthesis of evidence from medical literature that exists, published or unpublished, and this is what it's one of their key databases, Cochrane databases. So which again begs the question, what are systematic reviews? You already know it, most of you, but I'm just going to highlight some of the key features of a systematic review. So secondary research, there's primary research like the kind that Professor Dhara is doing, that like some of us do, where we interact with patients, we record observations, we publish it in journals, we compare it to a comparator, and that is primary research. Secondary research is sitting here, I look up available evidence, available literature, see what is relevant to my topic or question, bring together evidence, and then publish my research. That becomes secondary research. So systematic review is one of the study methods or designs for secondary research, but it is one of the key designs. And I have said that it attempts to find an unbiased answer to a specific research question by systematically looking through all available literature. Now, all those keywords have been highlighted in yellow. And because it is doing all that if one set of reviewers was doing it and another set of reviewers was doing it, if they were following a protocol, it will be replicable, which is why Cochrane reviews which follow this methodology is likely to be unbiased and have produced answers which are closer to the truth. Right. And what do we know about reviews so far? Reviews could be narrative or what are also known as traditional reviews, where the answers may not always replicate. So if you had a question and one set of reviewers or one person was looking at answers in literature, and another person was looking at answers in literature and not following the prescribed methods, the results could be very different from the other, one from the other, which is why the risk of bias is high. I could only be looking for answers of the information that I have. I may not be looking for answers everywhere. So, which is why the risk of bias is high, because search of literature is not systematic. There's no pre-specified criteria for selecting studies, for extracting data, and hence may not be replicated. So they may not always tell you the truth. Systematic reviews done properly are likely to tell you the truth, right? So I'll just go back to those 4 keywords I was talking about: specific research question, answering it in an unbiased way, using systematic methods, and using a comprehensive literature review. So the first question we are trying to answer, what is a specific research question? Okay, let's first look at what is a non-specific research question. So this could be, what are the ways to improve IVF results? There could be 100 ways to improve IVF results. And so you could look at all possible, right from stimulation, patient selection, to, embryology laboratory issues, which are not one, but many. And then finally, luteal phase support and other things, several things. But if you had a specific and one thing you're trying to answer, the question could look like this. It's a very specific, narrow question. Does universal ICSI lead to improvement in live births in non-male factor infertility? So a specific question will have the PICO format, wherein you have a population defined, non-male factor infertility. You have the intervention defined. You have a comparator, which could be IVF in the same population, and you're looking at an outcome of live birth. So wherever you have your PICO defined, and all systematic reviews will begin with the PICO question. That is how we define a systematic review. Some systematic reviews will also look at broader questions, but each of those systematic reviews would be divided into narrower, sort of multiple questions with each of their PICOs defined. So this is how you ask a question in a systematic review. Now, I used the other keyword was looking at all available literature. Now, all available literature could have been published and may not have been published. So published and unpublished, how do we know some of the literature is not published? So one example could be that, several trials have been registered in the clinical trial registry database. Not all of them have been published, right? Why? Because sometimes either because it's taking too long to recruit, but one of the answers could also be that they did not find the evidence to prove the hypothesis that they were trying to prove, right? So there is then a publication bias, which is why systematic reviewers need to look at gray literature as well, look at all databases, not just at PubMed, and type in the right keywords so that and use all kinds of languages, not just English, but all published literature in all language, which will lead to a more comprehensive literature search. Any variations in these could lead to variation in searches, different outcomes in kind of study selection, and that would lead to different results as well. Okay. So hence, whenever we're doing these guys, when they do a literature search, it is replicable. And they document the search that these are the databases they looked into, this is what they had, and these are the languages they use, these are the key phrases they use, right? The third keyword I used was unbiased. Now, once you have used your search coordinator has looked at all the studies that you wanted them to look at, they give you something like 150, 200, sometimes 500 studies to go through. Now, all studies may not be dealing, so he used the keywords, but you are supposed to pick up the ones that are relevant to the study question. So once again, when this study selection is being made, a clearly defined inclusion and exclusion criteria is used, which has been published prior, so that you don't make any changes while you're making the selection. And of course, there's a dual review, which means that one person is looking at the studies and the other is looking at the study, and they have to concur. If they don't, then they have to discuss why they don't concur and which studies have been included or excluded. And of course, see if they can concur on it. If they don't, then of course they have to write this in their publication later, in their research paper, why a certain study was excluded. Again, the unbiased not just is limited to study selection. It is it extends to data extraction. It extends to grading the kind of studies that you are looking at. So assessing bias, assessing heterogeneity. right? So, and then finally, they do what is known as the data synthesis. Data synthesis is a quantitative analysis in which you will use a meta-analysis, or if there is not enough evidence or material for a quantitative, then you do a qualitative synthesis. Now, most of the reviews that you and I will encounter in our disciplines will be quantitative synthesis, so we'll focus on this. What they'll also do is look at sensitivity analysis, look at alternate scenarios, that if this was not there, what would the results look like? So they're doing all of that in their synthesis, right? And finally, they come up with an answer for us. And that answer will tell us whether a thing is working or not working, and how much confident they are when they say it's working or it's not working, right? So that is the average time taken for a systematic review. Clearly, I mean, it's not a one-day job. It's not just by, you know, your data operators looking at studies and throwing them at you, and then you do a cursory, perfunctory search and you say, oh, it's working, it's not working. So this takes much, much longer. So, which is why we have to rely on Cochrane reviews. One, because they are unbiased. Two, because the replicability is very high, so likely to be closer to the truth. They provide a reliable basis for decision making. And it's not just one question, they could be answering many questions, right? Look at this. So Cochrane reviews, Cochrane, we know, is this international organization. It has several groups. There are about 53 such. To gynecologists, perhaps these three groups might matter: gynecology and fertility, pregnancy and childbirth, and fertility regulation. And the gynecology and fertility group, within the narrow field that we operate in, has published 270 reviews and 134 in infertility, right? This is what the gynecology and fertility Cochrane page would look like. So 134, you can see that there will be lots, but I've just brought out the first three. So now that brings us to how to read a review. Most of us already are aware of it, but I'm just going to be highlighting key points. Now, let's say you had this question. This is embryo glue is something a patient of, and they keep coming back to us. 3 failures, and they wish to explore what else can be done. You have discussed, so there are embryos lying and they need to be transferred. And she comes and says, I want to know if embryo glue is helping, and if at all you could use that to improve my chance, right? So we go first to Cochrane, and we find that there indeed is one of these reviews, hyaluronic acid in embryo transfer media for assisted reproduction technologies. It has been published, and it is as recent as 2020. I am interested. I also find out that the concentration of hyaluronic acid, most of the present culture media have hyaluronic acid because it is a macromolecule. It is supposed to serve several functions, and it is there right from the beginning to the end of culture. But either it's there or it's not there. But if it is there, it is in low concentrations. And if you are using it as a glue just prior to transfer, it will be used in higher concentrations, much higher concentrations than what is present when you're culturing those embryos. So approximate time, it varies, 10 minutes, maybe more, half an hour, and something like that. So we quickly go to their summary of findings tables. Somebody has already done this for us, so I'm not going to go into their methodology. We believe in Cochrane methodology, so we're not going to do a critical review of that, but we look at what they are telling us, right? High versus low, so that is high, 0.5 versus low, which is 0.125, or no hyaluronic acid for assisted reproductive technologies, okay? That is their couples undergoing transfer, that's their PICO, assisted reproduction settings, intervention, high hyaluronic acid, comparison, low or no hyaluronic acid. And outcomes, they've studied 5 outcomes here. Let us first look at live birth. So if, and this is illustrative comparative risks that they are giving us, what will be the incidence rate of the event? Event is live birth. So 333 per 1,000. If it existed where you're not using embryo glue, it will go up to 403 per 1,000 where you're using embryo glue. Okay, in brackets is 95% CI, and you see that the lower limit 370 is still higher than 333. So this might be significant, right? So which is why the relative risk is 1.21, which is 1.11 to 1.31. Again, it is above 1, so this is significant, right? And we look at the number of participants, which is 4066, which is quite significant. It is quite enough to give us enough confidence what they are saying. And of course, they grade it for us, which is moderate grade. What moderate grade means is that what we are saying is most likely true, but there is a possibility that the future research, there is a possibility, maybe however small, there is a possibility that future research might change this. It might bring it up or down. Okay? And look at this. So this is also a very significant figure, number needed to treat or harm, 14, which means that I'll have to treat 14 such patients of implantation failures to actually bring about one extra live birth. Is that remarkable? Maybe not. You know, if I look at it in the longer sense, yes, this is a significant result, but 14 results, 14 pregnancies or 14 cases I'll have to treat to cause one live birth improvement. Okay. So they will also give us this, and this is a significant thing. We must pay attention to this last paragraph, which is how reliable are these results. We are moderately confident about our results for the number of live births, clinical pregnancies, multiple pregnancies. Our results may change if further evidence becomes available. They are still open to this. This is not the final word. We are less confident about the rate of miscarriage and the number of adverse events because results for these varied widely. So in their summary table, they said that miscarriage rates might be lower, okay? But they say we don't have moderate evidence for this. We have low quality evidence for this, right? So now I also wanted to know whether, these results are favoring a specific subgroup, right? So we might have women with RIF, advanced maternal age and all that. So we are looking at, and so they do a subgroup analysis as well, these guys, and they tell us day 3 versus day 5 equally effective, frozen versus fresh equally effective. It wouldn't matter if you're doing a frozen versus fresh. Timing of exposure, effective when exposure is more than 10 minutes is what they tell us. But for RIF and for AMA, data is not available. So we'll have to hold our horses there. But yes, pretty much right now, it seems to favor embryo glue, although it's not like it's too suddenly it's magical. It's 14 cases treated for 1 increase in live birth, right? So you could always be skeptical, and we could ask this question. They don't always have an answer. It's true, they don't always have an answer because they don't have enough trials to work upon, or the trials are of poor quality. So let us say we had this question, should we be doing ICSI for non-male factor at all? And they do have a review, intracytoplasmic sperm injection versus conventional techniques for oocyte insemination during in vitro fertilization in couples with non-male factor. And we find that this is from 2003. So there is scope for improvement. I couldn't come across another review in Cochrane, which is later than this, a version later than this. So and they in 2003, they conclude that whether ICSI should be preferred over IVF because they have just one study to work upon. We are not sure, it's an open question. So go ahead and do your own research, right? So when Cochrane does not have an answer, you and I, all of us should have some skills to do a basic literature search, okay? Now, although I have said that PubMed does not have all the answers or all the studies, but it has about 99% of the studies or questions, relevant questions that one might want to ask. Of course, it's published literature, unpublished literature, this one may not have. So you might have to do, and we are not systematic reviewers. We are still looking at whether this is good or bad. What is the published literature saying, okay? So this talk is not about literature review, but I'm just going to tell you that what I did was I used some niche terms, which is ICSI and infertility female, not male, and it throws up 671 results. When I do review, a systematic review, it throws up 55 results. And within those 55, I go through each one of them independently to find that 5 are relevant to the question that I'm asking, okay? And so I look at each one of them. The first one, of course, is giving me a lot of confidence. Practice Committee of the ASRM and Society for Assisted Reproductive Technology. It should have the answers. However, remember, these guys are doing a review, not a systematic review. But just a quick look at what these 5 reviews or systematic reviews are saying. 2013, 11 trials, ICSI increases fertilization, lowers TFF, which is total fertilization failure. However, we need trials to determine if live birth rates are improved or not, okay? 2020, there are 3 reviews, nothing in between. And you can see they have different sets of trials that they have included. Fertile Sterile, of course, brings in women more than 38 and all three of them are saying that there are no difference in fertilization rates. The last review is able to assess clinical pregnancy rates with IVF in both the arms and find that clinical pregnancy rates might be higher with IVF than compared to ICSI. Finally, ASRM, which we all have, it's a high body in medicine, reproductive medicine, we kind of trust it. So they say that non-male factor infertility or a history of prior fertilization failure, the routine use of ICSI for all oocytes is not supported by available evidence. Fair enough. So this is what we will go by, right? Now, not every question may have that kind of answer, not on Cochrane, not in terms of systematic reviews. And what do we do then, right? So we do know that evidence-based medicine is a sum total of clinical expertise, which is knowledge and experience, research evidence, primary or secondary, and patient values, expectations. We try, so it is at the intersection of all these three. What happens when research evidence does not exist? Well, it could be based on clinical expertise. However, and all of us tend to use our best knowledge, and we always tend to act for the patient. However, there could be a case made for some of us not updating ourselves enough and not constantly staying in touch with available literature. And so some of us may have had been practicing routine hysteroscopy prior to IVF, routine endometrial scratching, routine PGTA, where there is evidence that it is not helping at all. Some interventions like larger trials have told us hysteroscopy or endometrial scratching may lead to an occasional infection, and it's not really doing much in terms of implantation in first IVFs. Let us just give it up, right? So update ourselves first before we kind of make that decision. The second is that there genuinely may not be enough evidence. And so what do we do? ERA is something that a lot of us have started offering after implantation failures, after 2, maybe after 3. We don't have strong evidence really to say that ERA works. But for those of us who have been using ERA routinely, the onus of proving that it works then rests on our shoulders, okay? However little cases we have, we need to probably come together to try and compile evidence in an objective way that is scrutinizable, that stands the test of scrutiny across observers from the world, and that will tell us whether or not this works, yes or no. We always do it against a comparator, so we have to adopt the right study methods to generate objective evidence. So what if we are not doing that either? It's completely a new intervention. What about what Professor Dhara was talking about, you know, something like organ regeneration? Well, he's still not proposing it as a clinical practice, but what about uterine transplants? So we have no literature, we have no experience. What should we go by? What our seniors are telling us? Well, we could, that is true. But you have to try and wait, you know, critically think this out, understand the mechanism of action, population that it will potentially benefit, weigh the costs of intervention, theoretical benefits and harm. You don't try to push it as a miracle cure. Give a complete picture to the patient, pluses and minuses. And if you are not convinced, continue with established practice, okay? That it's all right to kind of not adopt the new intervention. It's all right to continue with established practice. And some of us might say, but you know, she's failing repeatedly. I would want to do something. This is not what the patient accepts. You know, it might even work as a placebo. Then we have to know this, and we all know this, right? At the back of our mind that it's not going to work each time. Implantation rates do not exceed 15 to 40% by embryo, blastocyst respectively, and that it is those little things that we have always been doing have worked in most cases, right? Individualized stimulation, lab culture, and all those that you have learned throughout. So it is sometimes upon us to convince the patient, and this is as truthfully as possible, that it is all right. It is all right. We could try again. This is a matter of chance. 15 or 20% implantation per embryo is, and failing 2 times or 3 times does not mean there's something wrong with you. We can try again. You don't perhaps need, and I have worked you up fully. I have looked at your uterus. I have looked at everything else. We could just try again. All right. So with this, I end the talk. I hope I haven't exceeded my time. I may have. But if one was looking at improving decision making, there is no bypass to basic reading, to looking at recent research, and to becoming familiar with literature search, right? Thank you so much.
Thank you, Dr. Ruma, for your excellent presentation. Hope good guideline in clinical practice may help translate research finding into healthcare. Thank you again.
What an interesting session, ma'am. Do you want to ask any queries or questions?
Dr. Ruma, many times we see in our practice, key evidence is not there. Suppose recurrent implantation failure, there is no reason for that, and patient are asking. Patient have seen in Google that ERA is there, then scratching is there, PRP therapy is there, and they ask us to do that.
Yeah.
So in our, what to do in such situations?
Yeah. So let me take the example of PRP. And so PRP is, they've used platelets, and in fact, they've used platelets since I saw one of the first papers being published in 1993 for improving endometrial thickness and for improving implantation rates. And so much so that there seem to be reviews as of now, systematic reviews, incorporate. They're small studies. Most of them are pilot studies having 25, 30, 40, 45 patients. And if you bring these studies together, it's the total number might be about 600. And they tend to say that it might improve clinical pregnancy results, right? The point is that when we, should I adopt it or not? Because there seems to be, I would still look at it critically. I would look at it because one thing in my head is that we all know through our studies of molecular basis of implantation that at least 2,000 molecules have as of now been identified that might be involved in, this is primary research, laboratory research, might be involved in implantation. These are upregulated and downregulated, okay? Now, when we talk about PRP, you're introducing one of those molecules, maybe increasing the level of that and hoping that perhaps, that one will kickstart a process that will improve the entire endometrial receptivity, okay? Now that somehow doesn't hit very well with me. The point is that, if there are so many molecules that have to be at the right level, some up, some down at a certain time in implantation, and it is just one molecule that we are laying the onus of implantation on, platelets or platelet-derived growth factor, it somehow just doesn't hit home to me. So I would like to wait for evidence, stronger evidence. But when I say stronger evidence, maybe a larger RCT, maybe we could start this year, that can come up with an unbiased assessment of whether platelet-derived growth factor is working or not as something that improves implantation. I wouldn't want to jump to it. I wouldn't want to. So when I counsel my patients, I might tell them that this is what is there. This is what I feel. And I don't think it is doing much in terms of implantation. If you still wish to go ahead, then this is the doctor. You could go to this doctor. I'm not the one who's practicing it yet. Okay. Yeah.
Thank you so much.
Yeah.
Thank you all speakers for their excellent presentation. Swati, now we will conclude this session.
Okay, ma'am. Thank you, Dr. Sunita Sharma, for chairing the session and making it so interactive and so interesting. And thank you all the speakers for their wonderful and informative presentation. Thank you, Dr. Gopinath. Thank you, Professor Dhara. And thank you, Dr. Satwik, for giving such a knowledgeable presentation. So we will conclude here this session. Thank you all again.
Thank you.
Oh, okay, thank you, ma'am. So we are concluding the session, and the session will again live after TC Anand Kumar oration. You are on mute, ma'am. Swati ma'am, you are on mute.
I'm saying now it will be the keynote, lectures. Yeah?
Lectures, yes.
Okay.
After TC Anand Kumar Oresan.
Okay. Thank you so much.
It is held in Hall A, so you can join.
Yeah.
You can watch from YouTube link I have posted in.
Sure. Okay. Thank you so much.
Okay, thank you, ma'am. Hello, sir. Hello, Solaris, sir. Hello.
Hi there.
Yes. Sir, it will be start at 2 p.m. IST, Indian Standard Time. So, according to the program, you
Which
will
is
have
9 minutes from now.
But actually, right now, TC Anand Kumar Oresan going on holiday.
I understand, but that's not my problem.
Yes. After 1 hour, then we are late due to that.
Okay, my apologies. In that case, I've got to go. I can't wait for another hour.
So if you have any recorded session, you can send me.
I don't have a recorded session. I'm not prepared to do one now. I can't do it. I can do my talk now if you can record it. Are you prepared to do it? I can speak live now.
No, right now I can record. Actually,
Okay,
it's
well,
live.
you need to tell your organizers then that I can't wait for another hour. I'm leaving.
Okay, sir. I will inform.
Thank you.
Hello, sir. Just wait for 1 minute. I will start. Okay, sir.
Okay, no problem. Thank you.
Yes.
Welcome, Shiladitto. After all these hassles, I'm so glad that we could at least do it.
I'm sorry, I'm being difficult.
We should be sorry. We should be apologizing to you. In spite of
গৌতম দা বিশ্বাস করবেন আমার বাড়ি ভর্তি লোক বুঝছো তো উইকেন্ডের জন্য এসছে
বুঝতে পেরেছি না ঠিক আছে and say hello to Shohini আর
I will do, thank you.
আমি পরের বছর ইংল্যান্ডে গেলে তোমাদের কাছে দেখা করব গিয়ে
নিশ্চয়ই এসে থেকো আমাদের সঙ্গে you're very welcome
ছেলেও ওবিজিওয়াই করবে ঠিক করেছে আমি ওকে বারণ করেছিলাম কিন্তু আমি ডাক্তারি পড়তেও বারণ করেছিলাম তো বললো না ডাক্তারি পড়লে ভালো বাড়ি কেনা যাবে আমি বললাম ও তাই নাকি
তারপরে there is that তো কি কোথায় ট্রেন করছে
ও ব্যাঙ্গালোরে এমবিবিএস করেছে so he has just completed his NEET exam he doesn't know where he's going to get
right
he has a possibility of getting it in one of the central institute as well
excellent
পরীক্ষা হচ্ছে 14th of November যদি বা পিজিআই পেয়ে যায় ভালো তাহলে আমি বলেছি কলকাতায় করতে কারণ কলকাতায় করলে আমি একটু ওকে সুপারভাইজ করতে পারবো
হ্যাঁ নিশ্চয়ই
তোমাদের কাছে পাঠিয়ে দেবো
absolutely
hello Gautam sir hello
tell us whenever you're ready
yes sir I am showing the CV of Dr. Shiladit Bhattacharya you introduce them and then he will start okay sir
please record this and show it
yes
yeah can I share my
live
screen
we are going live
okay
yeah just show the CV blast good afternoon, ladies and gentlemen. It is my great pleasure to introduce one of my greatest friends since last 40 years, I suppose even longer, maybe nearly 50 years. We started our medical journey together in Calcutta Medical College. Both of us did obstetrics and gynecology in the same unit under Professor B.C. Lahiri. And after that, Shiladitto moved to United Kingdom. He got the gold medal in MRCOG from the Royal College of Obstetrician and Gynecologist. And he has been a true academician with several awards and prizes. It will take maybe half an hour to read his CV. But currently he is the head of School of Medicine, Medical Science and Nutrition in University of Aberdeen. He's the professor of obstetrics and gynecology, subspecialist in reproductive medicine and honorary consultant gynecologist. And what is most prestigious to all of us, he's the editor-in-chief of Human Reproduction Open. And finally, whenever we call him, he's from Bengal, he's from India, he never says no. And in spite of so many changes of time and etc., he has agreed to do a live lecture, unlike many other international and national speakers. So Shiladitto, thank you ever so much. The stage is yours and you're going to discuss a very important topic, which is a guideline for many of us who are working in the field of infertility, to freeze or not to freeze.
Thank you very much, Gautam. It's a real pleasure to be here with you today, this afternoon. And I'm sorry about being a little bit difficult in terms of not being able to accommodate some of the delays you've encountered. What I'd quite like to do is to get straight to my topic, and I'll start by sharing my screen. Let's see if I've got that going. Yep, that looks good. Can you tell me if you can see that okay?
Absolutely fine.
Okay, brilliant. Before I start, I'd like to thank and acknowledge my colleague, Professor Abha Maheshwari, who is currently just finishing off a national trial on this very question, on the freeze-all strategy versus standard protocols in IVF in the United Kingdom, and who shared some of her slides with me. So the first thing, I suppose, is to remind ourselves about IVF trends in the United Kingdom. So these are data from the Human Fertilization Embryology Authority. And of course, it's totally predictable that the number of IVF cycles should go up from under 10,000 cycles a year in 1991, for those of us who can remember that long ago, to just under 70,000 cycles in 2019. But what's really interesting is the rapid escalation in the numbers of frozen cycles. So those are shown in the yellow bars over the last 10 years. And of course, there are a number of reasons for that, not least because of our focus on a single embryo transfer strategy, which of course frees up other embryos which are surplus to the first embryo transfer, but of good quality and can be preserved for future use. But a major contribution to the number of frozen cycles is also a trend towards elective freezing of all embryos rather than put them back in a fresh cycle. Initially, the biological reasons behind that were that the embryos would be better if replaced at a more physiological point in time when the endometrium was more receptive to implantation, rather than at the end of an IVF cycle, which involves stimulation of the ovaries, generation of high levels of estrogen, progesterone, which inevitably have an impact on the endometrial structures and function. The expectation, of course, from a strategy of elective freezing of all embryos is A, to reduce ovarian hyperstimulation. And I think we've all had experience of how, particularly in an overstimulated situation, increasing the risks of pregnancy and continuing exposure to HCG can biologically exacerbate the risks of moderate to severe ovarian hyperstimulation. And but there's also an expectation that perhaps live birth rates in IVF might improve if we freeze all embryos and replace them at an appropriate point in time after thawing them. And lastly, there's also a tacit understanding that in some instances, perhaps obstetric and perinatal outcomes could be better. This is a unique area where we are inundated with the data from randomized trials. So I'm just going to take you through them, and I'll divide the studies, and I'm taking you up to 2020, that fall into two groups. The first are trials that have randomized what I would describe as a general IVF population or normal responders. And if we look at the trials, so there's a couple of trials from China, one on cleavage stage embryos, one involving blastocysts, a trial from Vietnam, and a trial from the Scandinavian countries. And the bottom line is 3 out of the four trials I've just spoken about show no difference in terms of live birth rates between women who've had fresh embryo transfers versus those who had elective freezing of all embryos. The one trial from China that was published in The Lancet in 2019 only compared blastocyst transfers, and in these, they found that the outcome was better in blastocysts that were frozen. Coming now to trials involving hyper-responders or women with PCOS, there are two trials, one a good quality trial from China published in the New England Journal in 2016, and another trial from Iran published in the International Journal of Reproductive Biomedicine in 2018. And both of them suggest that a freeze-all strategy is better in women who are likely to hyper-respond to stimulation. And in a sense, that echoes our thoughts around ovarian hyperstimulation and the risks that we run if we replace embryos freshly derived from women who've over-responded to hormonal stimulation. We're lucky, though, that a very, very recent Cochrane review published earlier this year, comparing elective freezing versus standard replacement of fresh embryos. And the primary outcome that this review group looked at was cumulative live birth, both after the first transfer, but also after subsequent transfers. And what that shows, and we are looking at it in three groups. The first is cumulative live birth for cleavage stage transfer, and that's right at the top. What you see is there are three trials, but reasonable numbers of women, over 1,000 in each group. The bottom line is that the combined odds ratio is 1.09, confidence intervals quite tight, actually, varying from 0.93 to 1.29, suggesting that there is no improvement in cumulative live birth rates associated with an elective freeze-all strategy. Next, if we look at trials that have specifically focused on blastocyst stage transfer, again, you can see 1, 2, 3, 4, 5 trials up to that point. Again, over 1,000 participants in each group. And again, showing no difference with an odds ratio 1.06, confidence intervals 0.88 to 1.27. So very even on either side of unity. If we combine data from both, and I don't see a problem with that, saying that they're essentially telling us the same thing, the overall combined odds ratio is 1.08, confidence intervals 0.95 to 1.22, showing, in my mind at least, quite convincingly that there doesn't seem to be an advantage of opting for an elective freeze-all strategy in all cases. I'm going to now talk about a couple of trials that perhaps we need to consider, which may not have been captured in their entirety in the Cochrane review. So this is Anja Pinborg's group from Denmark, smaller trial, about just under 500 participants. The bottom line is the overall direction of effect remains unchanged, with a relative risk of 0.98, confidence intervals 0.87 to 1.10. So really no difference between the two groups. The second, an even smaller trial from the Netherlands, is again important to consider in the totality of the evidence that we're considering, and showing again that cumulative live birth rates are 18% in the freeze-all strategy group and 28% in the conventional strategy group. So if you look at the relative risk is 0.62, so if anything, freeze-all seems to be slightly worse, but the confidence intervals, just because of the size of the study, are quite wide and straddle unity. If we now look at the time to pregnancy, and maybe this is a minor thing, but these are data from the Vietnamese trial from Dr. Lan's group. And what they've shown is very predictably, if you opt for a freeze-all policy, then your time to pregnancy will be slightly delayed. It's not enormously delayed. If anything, it's only a couple of months. But nevertheless, if that is a consideration for people, then that is something to take into account. Finally, if you look at the cost effectiveness of either strategy, and again, these are data from the Vietnamese group, I'll talk you through this. So on the y-axis, we've got the probability of a freeze-all strategy being cost effective. And on the x-axis, we've got a willingness to pay value expressed in euros. In any policy decision making that we take as a nation in Europe, our willingness to pay threshold for an intervention is usually around 20,000 euros. So I'm going to point out to you where that sits over here. And if at that threshold, so if you pay 20,000 euros and your expectation is that the policy you're supporting should be around 80% cost effective. In this case, we find that the cost effectiveness probability falls woefully short of that. If anything, it's barely just over 30%. And you almost have to be prepared something like 300,000 euros to get anywhere close to even 60% probability of being cost effective. In a way, I suppose you could have worked this out, because if you're going to add in the costs of freezing, add in the costs of storage, and then thawing and replacement of embryos, obviously that strategy is going to cost more than putting in an embryo at the end of an IVF treatment. And therefore, the expectation of that being much more effective has to kick in before your strategy can be demonstrated to be cost effective. So in a way, it kind of confirms what people would have intuitively believed. Coming now to other outcomes beyond live birth rates, there's a very convincing reduction of the risk of ovarian hyperstimulation in the Cochrane review. And this reduction is massive. So your risks of ovarian hyperstimulation are almost down by 3/4. So the relative risk is 0.26, tight confidence intervals 1.17 to 0.39. So even in the worst case scenario, your reduction of risk is over 50%. So that's quite a powerful statement. But again, I think you can work that out intuitively. If you don't put embryos back, particularly in women who already show signs of hyperstimulation, then obviously those overall risks will be lowered. And that's an important point. Now moving on to other outcomes, what's come out, which wasn't initially anticipated, was that the risk of hypertension in pregnancy seems to be higher following an elective freezing strategy. And even if you look at the studies that have reported them, and they're by no means all the trials that have actually reported pregnancy outcomes, the combined odds ratio is 1.8, so the odds are almost doubled. And you can see that the lower limit of the confidence interval is 1.23, suggesting that there's at least a 25% increased risk of hypertension. Not quite sure what the biological reason for that is, but the speculation would be that it's that process of freezing and thawing and all the exposures that an embryo might be exposed to potentially. Another thing that's coming out very clearly is something that was noted in the veterinary world decades ago, which they call the large calf syndrome in embryos which had been frozen and transferred later. What we are getting is a clear signal about large for-dates babies in pregnancies that have resulted from elective frozen embryo transfer. And again, that combined odds ratio is 1.96, suggesting that there's a doubling of risk, and the minimum increase in odds is 50%. So again, quite a powerful signal there. When we come to small for gestational age, it's obviously the other way around. So the risk of small for gestational age is reduced. And generally, that seems to be a positive finding for most of us, because of course, IVF on its own, compared against naturally conceived infants, shows an increased risk of small for gestational age. It's not very clear from the data we have at the moment whether that's iatrogenic due to early delivery or genuine effects of a slow growth in the uterus. But nevertheless, what we're getting here is we're trading in one risk for another if we go for a freeze-all strategy. So we get large babies, but we reduce the risk of small babies. These data are more speculative because they're single-center data. They are, by definition, as you can see, observational data, and the confidence intervals are wider, and that reflects the imprecision. Nevertheless, in a cohort of children in Massachusetts, where the comparison was between infants conceived from fresh versus frozen embryo transfer, the risk of infectious diseases, respiratory conditions, and neurological conditions, and I know these are slightly vague terms and are blanket terms for a number of different outcomes, even after adjusting for factors such as mother's age, race, education, parity, gender, diabetes, hypertension, PCOS, etc., a number of embryos, there does seem to be the signal suggesting that these risks might be higher in frozen embryo transfers. I've said initially that I'm not terribly convinced about them, and it's worth saying that because, of course, if you look at the lower limits of the confidence intervals, they are barely crossing 1. So it's 1.03, 1.07, 1.04. So it's kind of marginal. And one way of looking at this data is it may not really be an increased risk. Whereas, of course, if you look at the upper limit of the confidence interval, it could be doubled, it could be 40% more, could be 68% more. So speculative, but I think the key point here is we can't exclude the possibility of some of these risks. Again, a paper from Denmark, which has this unique ability to link population-based data. The risk of childhood cancer for children born after the use of frozen embryo transfer compared to children born to fertile women. So it's a different population here, significantly increased. And of course, there's a difference between statistical significance and a genuine population-based increase in risk. So it's absolute rather than relative risk that we're talking about here. But the hazards ratio at 2.43 does seem to be something we can't ignore. But interestingly, this risk did not persist when the authors compared children conceived through other forms of assisted reproduction technology, including IVF as a whole, ICSI as a whole, or hormonal treatment, so ovarian stimulation. So again, my interpretation of this is there could be a risk and we need to be mindful of that. Although one study, observational, we can't be totally convinced that we've proven that there definitely is this risk of cancer. I mentioned earlier that my colleague in Aberdeen is leading a multi-center UK trial. It's very tempting to give you the results, but unfortunately, we are in the process of publishing that as of now, today. I'm not able to share the outcomes with you. You just have to wait and see. But it's interesting, we've completed the trial in a UK setting, and we've also looked at costs. So if I pull all that together, what are we looking at? So I think the first observation is that in a general population of women undergoing IVF, and by IVF I include IVF and ICSI, live birth rates and cumulative live birth rates do not seem to be increased by a strategy of elective freezing of all embryos. That's the first observation. And these are data from a respectable population who've been randomized to either freeze all versus a conventional fresh embryo transfer strategy. The second observation is in a subgroup of women, those who are known to respond vigorously to gonadotrophins and those who have PCOS and are therefore expected to respond vigorously, live birth outcomes are better if embryos are frozen and there is this disconnect between stimulation and embryo transfer. And again, intuitively, you would believe that, wouldn't you? I think the data are very powerful in showing that elective freezing reduces the risk of hyperstimulation to the point where in day-to-day clinical practice, if you genuinely are facing somebody who has this risk of hyperstimulation, nobody in their right minds now would put fresh embryos back. And I think we're all agreed. Again, coming back to a general population, a freeze-all strategy is not cost-effective in everybody. Now coming from hard randomized data to observational data, although with hypertension and large for dates babies, if you remember, the Cochrane review suggests that the same direction is preserved in randomized trials as well. We now have reasonable data on which we can rely to suggest that a freeze-all strategy is associated with hypertension in pregnancy and is associated with a higher risk of babies being large for dates, although there is a lower risk of babies being small for gestational age. The data I've shown on other risks in children beyond the perinatal stage in terms of respiratory and other infections, neurological conditions, potential malignancy, those in a sense are hypotheses that possibly need to be proven and replicated in other studies. My interpretation of that is we haven't been able to rule out these risks with convincing data. So if I pull that together, I'm not sure that we can make a strong case to justify the use of a freeze-all strategy in all comers, i.e. in all women undergoing IVF. But there is enough there to empower us and the women we look after to make individualized clinical decisions. So certainly in women who are at risk of ovarian hyperstimulation, I think it would be reasonable to go for a freeze-all strategy. In women in whom you are concerned about large foot dates, I think you might need to have a think about that. But as with most of these things, and this is particularly trendy at the moment where we're all talking about stratified or personalized medicine, and also if you look at the more broader definition of evidence-based medicine, which is the judicious use of the best quality evidence to provide care that is aligned to the preferences and the values that individual patients have. I think we've got enough there to allow us to make clinically satisfactory, but also satisfying decisions for us and our patients. Thank you very much. And I'll just end with a picture of my university and hospital. It's been great speaking to you. Thank you all very much indeed.
Thanks ever so much, Shiladitya, for that wonderful presentation. You have summarized it so well. It's so helpful guideline for the clinicians, and we actually follow what you have already said. Freeze for all is very expensive, particularly in Indian scenario, and also the patients don't want to prolong the treatment for such a long time. Now, there is one question which is not really in connection with your talk, but there's a question from Ruma Satwik, who asked, do you have any objective cutoff in terms of oocyte number or hormone levels for defining hyper responders?
Well, that's a brilliant question, isn't it? And as you can imagine, that is a very context-specific question. So absolutely. In general, with most clinics in kind of my setting, anything around 20 oocytes, 22 oocytes, that's the kind of point where people think that your response might have been a little bit exaggerated, and people would worry about putting a fresh embryo back. So going back to the spirit in which the question was asked, it's one of those cases where you would need to do a proper study where you would associate the risk of ovarian hypertension with the numbers of follicles you see on scan and the number of egg recover. The problem is, of course, now, given what we already know, we wouldn't want to chance our arm and go into those settings. So in a way, you're not likely to find the robust answer that you're looking for. But I think around 20 would be a reasonable number, but it's not based, obviously, on the best quality data you would want.
I will ask my co-chairperson, Professor Hiralal Konar, to comment on this topic, particularly taking into consideration the obstetric outcome of assisted conception. Hiralal Da.
Well, though I would see the topic in the perspective of the obstetricians and gynecologists, general obstetricians and gynecologists, though I have got my little bit of experience with you and IRM Institute of Reproductive Medicine, Professor V.N. Chakravarti. Well, obstetrics outcome, we are getting patients in our government hospitals. Professor Bhattacharya, I don't know whether you have got the experience that we are getting cases these days that of pregnancy following the use of assisted reproductive technology, maybe the IVF or ICSI, for the management in the pregnancy outcome management, meaning that they are in advanced state of pregnancy coming to us. Obviously, our experience is that, as you have mentioned in your presentation, hypertension disorders in pregnancy, otherwise known as the preeclampsia, is common. And whether we are in a debate with sir the other day, we have got a publication also that whether it is related to IVF or the ART, or it is just characteristics of the pregnancy itself that we are getting this problem. This is one. Obviously, the other way that of the risk protocol, management protocol is really specialized, and often we have to go for early termination of pregnancy because of the several reasons of multiple pregnancy, or that of polyhydramnios, or some other reason of hypertension, or growth restriction, that we have to go for early intervention. Obviously, that means the problem of preterm baby, prematurity, and that involvement of the special neonatal care unit. So we are by these days, almost all the government teaching hospitals, we have got the nice management protocol for the neonatal part also. So we are dealing, we are seeing, and we are managing such cases. My experience goes with this.
Now, I would end by saying the most important, I want your opinion, Shiladitya, on this, is the best advantage of freezing is not to transfer more than one embryo. So if you have all these embryos, let's transfer one first, be it fresh or frozen, and then utilize them one after another, not being greedy, putting all of them together, and think about the cumulative pregnancy rate. And that is how we can reduce poor obstetric outcome. That is my personal feeling. The most of the adverse obstetric outcome are due to multiple pregnancy and prematurity. So the practice in India is to put too many embryos to get quick success, but the success is not pregnancy test. Success is not an ultrasonography photograph. Success is taking home a term baby, a single term healthy baby home.
Absolutely.
And this is the message. Shiladitya, please emphasize and give your opinion.
No, absolutely. I couldn't agree more. And of course, I'm in a slightly different environment because the Human Fertilization Embryology Authority has launched a campaign now, which is almost a decade old. And you can see the results. If you look at our more recent data, I mean, our multiple rates are really low. So in national data now from most clinics, you're going to get multiple pregnancies in low single digits, to be honest. So we don't have that problem at all. And where I think people genuinely feel that you increase your chances of conception by putting all your embryos in one basket, and I know I'm mixing metaphors here, the clear message to them is you're multiplying risk as well.
But you have, the law tells you can transfer two, isn't it? Unlike Scandinavian countries.
Yeah, no, we can in some cases, and of course there are extenuating circumstances, and all clinicians will be aware of that, where you have multiple implantation failures, etc. I mean, there could be situations where you could transfer one, but the advances that our colleagues in the lab, now this is the right venue to give them the credit for that in terms of prolonged culture, in terms of freezing, thawing techniques. I mean, we don't have that lack of confidence we had in the past, where if you froze embryos, you didn't know whether you would ever get to thaw them and use them successfully. So there's absolutely no reason to be afraid. If you have embryos and they're good quality, they will survive, and therefore it's best to minimize the chances of multiples by putting in one at a time. And also, logically, it doesn't make sense. Putting in two good quality embryos does not necessarily help each of them to implant. Both of them have the same chances separately. And we need to think beyond implantation. And of course, we then have fetal losses after you see a heartbeat. So you've got the vanishing twin syndrome. You have all kinds of problems. And the biggest risk is if one twin does not survive, that genuinely impacts on the other in terms of pregnancy and neonatal outcomes. So for all these reasons, I think we are convinced. Our patients are now very worried about having more than one embryos put back. So I think the real debate, the real conversation is not just in the medical or scientific circles, it is bringing your patient population with you so that they can make genuinely informed decisions.
I mean, that can only happen if you counsel them properly. If
absolutely, and they hear everybody, yes, everybody in the profession saying the same thing, the consistency of message.
Hiralda, you wanted to say something?
Well, that's okay. That's okay, fine. Yeah.
So, Shiladitya,
that's important. Gautam, that's important that what Shiladitya has stressed on that, taking patient in the counseling. Obviously, they are keen to get their baby at the cost of anything, even their life. This, our social situation is like this. But again, then, when as a clinician we feel that outcome is going to be the same in one or with the two or the three, so why we should waste our money and energy with this and creating trouble at the end of the day? So that's a good decision. Involve the patient herself or the relatives themselves in the counseling process.
Thank you, Shilalito, ever so much once again for your participation.
Yeah, we are very happy.
Participated and we could finish it within a reasonable period of time. That is the most important, to keep your family happy as well.
Sure.
And my best wishes for them. Looking forward to meeting you all next year.
Yeah. Great.
Thank you very much. Thanks
Thank
a lot.
you.
Bye-bye.
Thank you. Thank you. Bye-bye. Take care.
I'm requesting Dr. Swati to introduce the chairperson of the session, please.
No, this is, are we continuing with the,
yes.
Continuing with
we are
the
continuing.
Next speaker?
Yes.
Can you switch on my video, please? It's not coming. You
Just
cannot. A very good afternoon, everybody. Now, the session has already started, but I will take this opportunity, and it will be an absolute pleasure for me to introduce our chairperson of this last session. First, I'd like to introduce Dr. Gautam Kastagi. Sir,
don't go in details because of the shortage of time. Just say as organizing chairperson, that would be enough.
Yes, but let me speak few sentences about you, sir.
Okay.
He's a recipient of a well-being research grant, RCOG London, published over 25 papers in infertility, hormone therapy, international journal, RCOG accreditation of subspecialty training in reproductive medicine and surgery, and level 3 endoscopic surgery. He's a medical director of birth and advanced fertility center. He's a head of gynoscopy and which provides hands-on training to over 250 doctors in gynae endoscopic surgery. He's a chairperson of ISAR Bengal State Chapter, elected member of ISAR Executive Committee 2020-2022, and he's a chairperson of Birth Inspire Foundation. He's the organizing chairperson of ACE 2021. A very welcome to you, sir. And our next chairperson is Dr. Hira Lal Konar. And it's absolute pleasure to be introducing you, sir. Sir is a FOXY representative of AO FOG 2018-19, and he's a member of Oncology Committee of AOF FOG. He's a chairperson in Indian College of Obstetrics and Gynecology, ICOG 2013. And he's a national editor of Junior Obs and Gynae India, editor-in-chief of ISOPAR. He's a vice president of FOXY 2008 and president Bengal Obs and Gynae Society 2008-2009. He's a recipient of Pride of FOXY Award 2019 for exemplary work towards upliftment of women health in India. He has a fellow and he's a fellow and member representative of AICC, RCOG, and author of textbooks of obstetric and gynecology, clinical obs and gynae for PGs. A very welcome to you, sir, and please take the stage and introduce our next speaker.
Thank you. Am I audible, Sati?
Yes, sir, you are.
Yes,
right.
You go ahead.
Thank you very much, Gautam. Thank you. At the outset, I express my sincere thanks to the organizers, Dr. Kastagi, Dr. Rafna Chattopadhyay, and the team, CE, for having this opportunity to chair this session that is on this fertility preservation. You know that we have already heard from Professor Bhattacharya. Now we are moving on to the next topic, that is oncofertility. Basically, fertility preservation is established now, though research started nearly 2 decades now. And it is not only for that of protecting the woman from the age-related decline in fertility, or to help those women having their family, having their childbearing at the late age. It has extended the horizon of the fertility preservation, has extended widely to the areas of oncofertility. As a general obstetrician and gynecologist, we see those women having the predisposition of cancer, they could be protected with that of the preservations, either the oocyte or the ovarian cortex or that the embryo. But those women that with some gynecological malignancy, that's really a problem. As a gynecologist or obstetrician, we treat them either by surgery, chemotherapy, or radiation therapy. As a gynecologist, we all know the surgery definitely declines the fertility, not only by removing the organ, but also by the residual additions, pain, and that of the sexual dysfunction. Chemotherapy is definitely gonadotoxic, and in young girls causes oligomenorrhea, amenorrhea, delayed puberty. So there is anti-chemotherapeutic agents, cyclophosphamide, alkylating agents, heavy metals that of cisplatin, carboplatin, definitely gonadotoxics and reduces the fertility significantly with the end result of premature ovarian failure, ovarian dysfunction. Radiotherapy is again significantly gonadotoxic, causing DNA damage with the problem of premature ovarian failure, impaired follicular maturation. And we all know with the radiation dose of even 2.5 to 3 GOI that causes total ovarian failure in the extent of 60% of the women. With this background, oncofertility and fertility preservation is a new area of horizon. We have got our expert with us, Dr. Michael DeVos. Ladies and gentlemen, to introduce Dr. Michael to you, he is a gynecologist since 2006, Senior Medical Director, University Ziekenhuis, Brussels, Belgium. He is the Associate Professor in Reproductive Medicine, Vrije University, Brussels. He did his PhD from the Leeds. Most of us would be knowing the university, Leeds University, UK, 2011. Michael has got keen interest in reproductive endocrinology and in vitro maturation of oocytes and fertility preservation. He is the principal investigator of photo, otherwise what is known as the freezing, ovarian tissue and oocytes preservation, with a keen interest in oncofertility. He is a founding member of the Belgium Fertility Education Initiative, BFEI. With this introduction, ladies and gentlemen, I request Michael DeVos to have his presentation. Thank you, Mr. DeVos.
Dear colleagues, my name is Michel de Vos. I'm a gynecologist and a professor in reproductive medicine at Vrije Universiteit Brussels in Brussels, Belgium. The field of fertility preservation has grown hugely in the last decades. There is increasing recognition of the importance of potential loss of fertility as a very important effect of the treatment of cancer. And second, there is the development of technologies of oocyte vitrification and ovarian tissue cryopreservation. This has led to a widespread but uneven provision of fertility preservation for many women and young girls worldwide. Today I will share with you our experience with fertility preservation in women and girls, and I will discuss the existing literature. Here are some disclosures. So, death rates from cancer are falling, but prevalence is rising or constant. So it must be the case that people with cancer have a better or longer survival rate due to earlier detection and better treatment. We see this clearly in the United States when we look at the change in 5-year survival rates across cancer types. As a result, an increasing proportion of individuals are cancer survivors. According to a retrospective cohort study of cancer patients in Scotland, cancer survivors achieved fewer pregnancies with a mean standard incidence ratio of 0.62 compared to a matched control population. So this means a mean reduction of fertility by more or less 40%, which you can see in this figure. In more recent periods, pregnancy rates in survivors of breast cancer, Hodgkin lymphoma, and cervical cancer have increased, but survivors of leukemia and brain tumors have suffered low fertility rates across all diagnostic periods. Ovarian function damage after chemotherapy and radiotherapy will impact on fertility and reproductive lifespan, but with great variability. Recovery of ovarian function depends on age, ovarian reserve, and the level of gonadotoxicity. Most studies have used outcome measures such as ongoing menses, with few studies reporting on fertility or age at menopause. Age at menopause has implications for the duration of estrogen deficiency, with its own adverse health consequences. And anti-Mullerian hormone after chemotherapy appears to be a weak predictor of short-term fertility, but a strong predictor of age at menopause. So what you can see from this figure is that women who have a high functional ovarian reserve before chemotherapy can expect to have a better chance of ovarian function recovery after chemotherapy, whereas women with a low ovarian reserve may have a very high risk of no recovery at all and ovarian insufficiency. Anti-Mullerian hormone is a very intriguing molecule and hormone for cancer patients in the context of fertility, because we know that anti-Mullerian hormone has important functions to control the recruitment of primordial follicles from the primordial follicle pool. Anti-Mullerian hormone also has an impact on the function of follicle stimulating hormone. And anti-Mullerian hormone has been investigated as a protective compound to protect the ovarian reserve during chemotherapy, because if in mice, if you add anti-Mullerian hormone to the ovary, the follicle recruitment as a result of the chemotherapy was lower. So mice after chemotherapy had more primordial follicles when they were treated with anti-Mullerian hormone during chemotherapy. Alkylators and platinum compounds are widely used in the clinical management of hematological and solid tumors in children and women of childbearing age. The two major pathways of damage to the primordial follicle pool is direct DNA damage to the oocytes, resulting in apoptosis of the oocytes, but also apoptosis of the follicles. It was found that follicles sustain more damage to the granulosa cells when the follicles are slightly larger. Secondary and antral follicles will be damaged through damage to the somatic cells directly, whereas in primordial and primary follicles, it will be the oocyte that will be primarily touched by the DNA damage and not the granulosa cells. So that's a really important differentiation. Follicle activation is also a mechanism whereby follicles are lost as a result of chemotherapy. And thirdly, damage to the vascular context of the ovary can also occur through fibrosis. The current impact of immunotherapy on fertility and on pregnancy is still unknown, but we will hopefully soon find out from methodologically robust studies whether immunotherapy has an impact at all. According to a prospective study in early stage breast cancer patients, the group of Richard Anderson in Scotland has found that a serum anti-Mullerian hormone level of 3.8 picomole per liter, which corresponds roughly to 0.5 nanograms per ml, predicted amenorrhea post-chemotherapy, and an AMH pre-chemo of 20.3 picomole, which is about 3 nanograms per ml, predicted menses after chemotherapy. And age is a very important modulator of this risk. And this model, I think, can be used to predict whether a patient after breast cancer will still have menstruation. To address the complex issues about fertility, healthcare, and quality of life, several initiatives have been launched in the past decade. Guidelines have been developed by several professional societies, including the European Society for Human Reproduction, but also the Oncofertility Consortium from Michigan, USA. Now, cancer patients should be counseled about fertility preservation. So this is a universal guideline where we would really urge oncologists to inform cancer patients about the impact of cancer treatment on fertility. Oocyte cryopreservation is an established option for fertility preservation. It's no longer experimental, and so is embryo cryopreservation. The same goes for ovarian tissue cryopreservation. It's no longer considered experimental. It should be offered to patients who undergo high risk or moderate risk for ovarian function loss, where oocyte and embryo cryopreservation is not feasible when, for instance, there is insufficient time to stimulate the ovaries. In that case, ovarian tissue cryopreservation is a good option. Or when the patient prefers to have ovarian tissue cryopreservation instead of oocyte cryopreservation, where women prefer not to have ovarian stimulation at all. Ovarian tissue cryopreservation should not be offered to women with low ovarian reserve, which would be an anti-Mullerian hormone level of less than 0.5 nanograms per ml, or women who have an advanced age. Women above the age of 36 years should be discouraged to undergo ovarian tissue cryopreservation. Maturation of oocytes in vitro is an innovative option. It is an interesting research topic where we also here in Brussels are trying to contribute to a better insight in the value of IVM in the field of fertility preservation. And in vitro maturation of oocytes can be done after transvaginal puncture of the ovaries, but it can also be performed in connection to ovarian tissue cryopreservation. And in that case, we name this technique ovarian tissue oocyte IVM. It's an experimental option, and I will discuss this briefly in a few minutes from now. The approaches may be combined. This is interesting when women want to have, to boost their chances of reproductive function in the future after cancer. It could be conceived that if you combine ovarian tissue cryopreservation with oocyte cryopreservation, for instance, that this could potentially enhance the chances for a baby. Now, there are some impediments to a more widespread use of fertility preservation. Why is the uptake of fertility preservation technologies still so low across the world? First of all, there is a lack of knowledge among oncologists. Many oncologists don't know the efficiency of oocyte cryopreservation these days. And of course, treating malignancy is a priority for oncologists and also for patients. It's really crucial to focus as much as possible on surviving after cancer. However, there should be also more weight that should be given to quality of life after cancer, which means the option to have a family after cancer. In many cases, cancer is a very threatening disease that requires urgent treatment, and the urgency of treatment is also very often an impediment to do fertility preservation strategies. There is a lack of referral strategies in many regions, also financial restrictions where patients have to pay fertility preservation themselves. There is also a lack of knowledge in general about fecundity. Often there is the misconception that when women still have menstrual periods after chemotherapy, that this would imply that they would still be fertile, which is obviously not always the case. There's also limited data of efficiency of fertility preservation interventions in patients who returned. Now let's have a closer look at our cancer patients who are referred for fertility preservation. Now, fertility preservation is not restricted to cancer patients, but can also be applied in women with non-malignant conditions and in women with the risk of premature menopause, including Turner's syndrome. We recently published our own data in Human Reproduction. According to our data, almost 50% of our patients had a diagnosis of breast cancer. And other important types of cancer were leukemia, lymphoma, cervical cancer, ovarian cancer, and brain tumors. Now, what's the proposed algorithm? And this algorithm has been published in the European Society for Medical Oncology Open Journal last year. Now, if a patient with cancer desires to preserve fertility, then for men or for boys, well, sperm can be cryopreserved after puberty, and a testicular biopsy can be considered in prepubertal boys. As far as female cancer patients are concerned, if there is time to stimulate the ovaries, and we would need approximately 2 to 3 weeks, then oocyte cryopreservation or embryo cryopreservation is the preferred strategy. If there is no such time frame available, then ovarian tissue cryopreservation can be considered, or a transvaginal puncture of follicles to obtain immature oocytes and to perform oocyte vitrification after IVM. Now, in any case, the administration of long-acting GnRH agonist during chemotherapy can be considered in women with breast cancer to reduce the chances of infertility. Let's give an example. Now, I'm going to discuss a nulliparous woman of 29 years old who was diagnosed with invasive ductal adenocarcinoma of the breast in our center, estrogen receptor positivity, progesterone receptor as well. The treatment that was proposed to this woman was neoadjuvant chemotherapy, and the oncologist agreed to extend the time interval between the referral to our service and the start of the chemotherapy with 2 weeks. Now, the patient had stopped the oral contraceptive pill. She had an AMH of 3.39 nanograms per liter, which is a normal and a good value for someone at the age of 29, and a total antral follicle count of 20. Now, if you take a closer look at this slide, then you can see that the day after the patient called us to be seen to receive counseling about fertility preservation, we already performed a blood test to see that she had baseline hormone values for ovarian function, and we started ovarian stimulation. And we used, in this particular patient, we used corifolatropium alpha, which has the benefit of requiring only 1 injection for ovarian stimulation, and the follicle stimulation is continued for 7 days with 1 single injection. So for cancer patients, this could be a beneficial approach. And then after 7 days, ovarian stimulation was continued with daily injections of gonadotropins, after which a GnRH agonist trigger was given, and the patient had an egg retrieval, 13 COCs were retrieved, and 9 mature oocytes were vitrified, and the patient started chemotherapy 2 days later. We also gave her a long-acting GnRH agonist trigger to trigger final oocyte maturation, but this trigger can then also be used as chemoprotection, which is at the moment it's an innovative approach, and this is being studied in prospective studies. Now, as you can see here, it only took us 2 weeks to perform fertility preservation, And we also used letrozole. Letrozole is an aromatase inhibitor to keep the estradiol levels in the serum quite low, as to avoid a stimulation of the breast tissue, because the patient had estrogen receptor positive disease. Now, how do you have to stimulate the ovaries? Well, the idea is, of course, to obtain as many eggs as possible, because you only have that one single chance to obtain oocytes in a patient before she starts chemotherapy. Now, if you look at the number of oocytes, so which is a parameter of ovarian response, then apparently, if a patient has a more abundant ovarian response with more oocytes, then there is no negative impact from the high number of oocytes on the euploidy rates in the embryos of these women. Which means, in other words, that there is no negative link between oocyte number and chromosome abnormalities in the oocytes. And this is a reassuring finding, which was published only last year in Human Reproduction. Very reassuring data for our patients. It means that a patient has to undergo a blood test before ovarian stimulation, and the blood test should give us a level of anti-Mullerian hormone in the patient. So we need to know the ovarian reserve category of the patient before we start ovarian stimulation. If a patient has a normal or a good ovarian anti-Mullerian hormone level, then there is no negative impact from stimulating the ovaries as to obtain as many eggs as possible. Okay. Now, there is also a lot of data now becoming available about the safety scores of oocyte vitrification. And Leoke de Monk, who is our head of the embryology lab, did some studies in this respect a few years ago, and she found that the epigenetic modifications of in the oocytes were minimal actually. So there was no difference in methylation levels between embryos derived from fresh or from vitrified oocytes. So she basically looked at methylation levels in the embryos on day 3 after fresh oocytes and vitrified oocytes. So this is also reassuring for our cancer patients who undergo oocyte cryopreservation. Now, what do we know about the return rates, and more importantly about the chances of having a live birth after using vitrified oocytes in cancer patients? Well, there are not that many data, but we learned from a study in England, Diaz Garcia, and a study in Spain, Ana Corbo, that the chance of having a baby after using vitrified oocytes in cancer survivors is more or less 1 in 3. Now, if we want to maximize the future reproductive options for selected patients with cancer, then approaches that combine different techniques have been investigated. And one of these approaches to combine the techniques is a combination of ovarian tissue cryopreservation and the retrieval of oocytes for maturation in vitro. So maturation in vitro, and this is also named ex vivo IVM. Why would that be ex vivo IVM? Well, because the oocytes are retrieved from ovarian tissue that is removed from the body of the patient. So it's ex vivo, it's from the body of the patient, and we look at immature complexes, which you can see on this slide under the microscope. These have a compact cumulus surrounding the oocyte, and the oocytes are incubated in standard registered IVM media for 30 hours. And after 30 hours, on average, 50% of the cumulus oocyte complexes will have a mature oocyte, a metaphase 2 oocyte. These oocytes are either vitrified or fertilized in vitro using ICSI. We have recently published our clinical data in women who had ovarian tissue cryopreservation and who had auto-IVM in connection to ovarian tissue cryopreservation. And we looked at 77 women who had this combined procedure. They were on average 24.5 years old when they had the ovarian tissue removed. There were also even 9 girls who were prepubertal at that time. And so what we can learn here is that on average, we were able to vitrify 6.7 oocytes per patient pre-chemotherapy. Now, these women all came back to the clinic with a wish to conceive, and in total, for 7 of these, 2 here and then 5 there, ovarian tissue oocyte IVM material was thawed, was used. 2 women had IVM oocytes warmed, of which 1 had a live birth. Then in 5 women who had embryo vitrification after auto-IVM, also 2 live births were obtained, and some women went on to have standard IVF after failure to obtain a pregnancy with this auto-IVM material. And some women did not have ovarian failure when they came back to us, and many of them got pregnant with fresh oocytes, which is also a reassuring observation. But what we can learn from this study is that the addition of IVM, of oocytes that have been extracted from externalized ovarian tissue, is a promising procedure, and should be a procedure that should be automatically connected with ovarian tissue cryopreservation. Pregnancy after breast cancer is deemed safe, so there is no increased risk for the survival rates when a patient gets pregnant after breast cancer. This was studied by Matteo Lamberti. Now, of course, there is an increased risk of obstetric and birth complications for female cancer survivors. This was shown by this study. And an interval of at least 1 year following completion of chemotherapy is recommended in cancer survivors. There should also be a specific washout period before conception. For tamoxifen, this is 3 months, and for anti-Herceptin treatment, this is 7 months. If a patient is hormone receptor positive, she has to be on tamoxifen for 5 to 10 years. However, it is now investigated whether it can be recommended for women who have a desire for pregnancy to temporarily interrupt this 5 to 10 years of tamoxifen to have a pregnancy in between. So we should perhaps allow them to get pregnant, and then after pregnancy they should continue tamoxifen. There has also been a study to which I contributed, a retrospective study in several centers in 39 women with breast cancer who had chemotherapy, who survived breast cancer, and who then went on to have IVF treatment with ovarian stimulation. So it appears, according to that study, that IVF treatment can be safely applied in women who survived breast cancer if they have favorable prognosis. So in fact, there is no difference with respect to recurrence rates in these women with breast cancer who got IVF treatment compared to matched controls who did not have IVF treatment. I'm going to be quite brief on that. Is a strategy that has now resulted in more than 200 babies born, according to the latest publication of Marie-Madeleine Dolmans from Brussels. 50% of conceptions are natural conceptions after ovarian tissue transplantation. And what is intriguing to see is that when you look at the anti-Mullerian hormone levels in the serum after transplantation, then if you look here at time 0, then you see a very sharp and temporary increase in AMH to return to normal levels very shortly after ovarian transplantation. So this is probably the result of a massive over-recruitment of follicles and the subsequent depletion. And when this depletion is stopped, then the ovarian transplant proceeds to function surprisingly normal for many years. Well, despite a low AMH level and a low remaining number of follicles. And probably this is because when the ovarian reserve goes down, the rate of loss of primordial follicles is also going down in a compensatory way, which was studied by Sherman Silber a while ago. Now, an important hurdle to ovarian tissue transplantation is the risk of reintroducing malignant cells. And the highest risk of reintroducing malignant cells after ovarian tissue transplantation was in women with a history of hematological malignancies, in particular leukemia. Now, according to recent data, it is recommended to give chemotherapy in these women before fertility preservation. So if you have a patient with leukemia, it is important to induce, so start chemotherapy as soon as possible to induce remission, to get rid of the leukemic cells in the tissues, and then perform fertility preservation. And this can be done between the induction chemotherapy and just before the consolidation chemotherapy. This is considered as a safe approach, and the first baby after ovarian tissue transplantation and screening of minimal residual disease was reported in 2018 by an Israeli. Now, last but not least, GnRH agonists, would they help or not? Well, according to the latest meta-analysis studies, it is probably a good idea to give GnRH agonists in breast cancer patients to protect them against amenorrhea and infertility. I would like to thank you for watching and listening. And last but not least, I would like to invite you to join our upcoming Oncofertility Congress, which will take place on the 8th and the 9th of October of this year. It's a virtual congress, and you can register to this congress by this QR code. Thank you, and see you soon.
Thank you. Thank you, Dr. Michel. Excellent presentation with this information regarding that of this fertility preservation, oncofertility preservation. It's a new concept, new idea, extremely benefited. I believe, Shati, is there any question for Dr. Michel?
There are no formulated questions, sir. If you like to ask something, you can do that, sir.
Right. Michel, what I was interested, as a laparoscopic surgeon, as you have talked about that of this ovarian transplantation, do you do that of ovarian tissue transplant, auto transplantation, and what sort of site that you select, and how is the experience of auto transplantation?
Okay, yeah, thank you for this question. So for autologous transplantation,
right,
after thawing of the tissue, so it's really crucial to have very good communication with the lab, because of course when you are putting the patient to sleep, you are putting your entry points to insert your laparoscopic tools, and then you have to prepare the site for grafting. And what we usually do is we start with a peritoneal window. So we deperitonealize a small square just underneath the the ovary, so in the ovarian fossa. That's most important when you have a patient who has patent tubes. So you have to test the tubal patency first while you are doing the laparoscopy. You have to use some methylene blue staining to make sure that you see that the tubes are open. And if you confirm that the tubes are open, then there is a good chance that the patient will have a baby after spontaneous conception. So then it's important to put the ovarian tissue very close to the natural sites, so the ovaries. So we deperitonealize the site, and then when we are ready, we ask the people from the lab to come over with the small pieces, and we put the small pieces on our instruments, and one by one we put them into the peritoneal cavity of the patient. And when we have put all the pieces in place, then we cover the site with some surgical gauze, and we use some tissue to close that window, to make sure that when you wake up the patient, the tissue is really going to be kept well in place. And then after 4 months, you measure the FSH level, the estradiol level, to see whether your graft is working or not. And in the meantime, you give the patient the combined oral contraceptive pill to suppress the ovary, to make sure that you can have a quiet ovary.
Right. What I feel that doing so, autologous ovarian transplantation, could there be any risk that we are giving back her these cancer cells?
Yes.
With this procedure.
Yes. So if you have a patient with breast cancer, what we usually do is we ask the histopathologist to look under the microscope, look at 2 or 3 small fragments to make sure that they do not see any cancer cells in tissue.
Great.
So for breast cancer, so far, this is a very straightforward procedure for minimal residual disease screening. However, for hematological cancer, it's more tricky, because there, what we have done is we have transplanted the tissue, 1 or 2 fragments of the tissue, into mice, into skid mice that are then during 6 months growing, and we have to see whether the mice are developing any cancer. So this is quite difficult and also quite laborious to do. One best strategy these days for women with hematological cancer is that you should, when a patient has leukemia, you should first give induction chemotherapy to the patient before you take out the ovary. You have to make sure that when you take out the ovary, the patient has already reached molecular remission. This is much safer. You will still have sufficient follicles in the ovary after the induction chemotherapy. So the risk of disease reintroduction is really very low. And then, if necessary, after the induction chemotherapy, the patient can have the ovarian tissue removed, and then she can start the consolidation chemotherapy, which is more gonadotoxic for the patient. So it's a new approach.
Correct. Thank you very much. We really benefited. Shati, is there any more question for Michelle?
No, sir. There are no more questions.
Right.
And so we'll conclude this session. I'd like to thank the chairpersons for chairing this wonderful and informative session. And I'll also like to thank all the speakers, Dr. Michelle and Dr. Bhattacharya, for such a wonderful topics and
excellent
an excellent topic and such informative new things we learned today.
We
And
learned.
yeah, very, very well prepared talk and very informative. Thank you, sir. Thanks a lot. And I'll also take this opportunity to thank you, Ace, for organizing such a wonderful session and for letting me coordinate it. So thank you all and have a wonderful rest of your day.
Thank you.
All the best. Thank you. Bye-bye.
Bye.
Okay, thank you, ma'am. So we are concluding. We are ending the session. हेलो संचित सर बंद करा दें यहाँ से हेलो हाँ संचित बंद कर दो
ठीक है ओके
और वहां से स्पॉन्सर वीडियो चला दो ठीक
ठीक है
ओके